Right. Mr. Better.
Honestly, go fuck yourself, sir. You don't say that, okay? You don't lose a trial where a jury acquits someone and finds them overwhelmingly not guilty and say, I gave my sincere obligation to look into this, and I'm telling you all I saw when she's guilty. Again, respectfully, go fuck yourself.
Is that a fair characterization? I think that, Your Honor.
I want to hear objection before I hear a word out of your mouth.
Objection.
Overruled. Sit down. Oh, I said overruled. Sit down.
Swear again like that. That was, no, I mean, whatever. That was, I shouldn't have done that.
A few moments later.
You, as a prosecutor, have got to be out of your fucking mind.
Nose.
Dude, Jimmy, look at those ears.
The ears don't bother me as much.
No, I don't trust a man. I don't trust a man with a lobe like that. No,
really,
not a fucking chance.
The mouth is butthole to me.
Very thin, paper thin.
The nose.
Oh, the nose.
The brows.
Well, listen, I will tell you though, I kind of like a fucked up nose on a guy.
I like a big old honker. I like a big nose.
Old nose. Give me that beak, bitch. You know?
Yeah.
Like, I'm into it.
Come over here. Cluck, cluck.
Yeah.
I see some chickens that went moving on up in my biz, cluck, cluck, running. You gotta be with the kids, the kids, the kids, the kids, the kids, kids.
And I go, oop, clutch, clench, kegel. We did it all. And I go, oh, and what happened? And they go, well, we just got 4,000 plus pages, bitch. And I said, stop it. Show me it. Take me to Unimpound Town immediately, if not sooner. So what happens?
The bitch is here.
Why are you at a football game? Are you a Fonz correspondent?
Well, no, because it's only for men over 30. Okay? Have a great night, boys. Fuck off.
It's been 1 week since you looked at me.
Hey, Blues Clues, motherfucker.
Hello, lovies. How are we? Today is Wednesday. It is August 5th, 2026. And we are together today to go over a lot. There has been medical testimony near, far, wherever you are. And in the Lindsay Clancy case, there was a couple of bombshells that I feel like hasn't been really addressed between yesterday and today that I personally was kind of shocked over. So I wanted to say hi. I miss you. Okay. And we'll do it together. So I have my handy dandy notebook. Okay. She's taken all the notes. What do we know? No. Why did she do it? We don't care. But she feels like an educated queen. Are we in class? Yes. Thank you for joining. Hi. Happy hump day. Hump away. Also to Jenny, not Jen. Thanks for saying that Montate doesn't have a lobe like an Adelson. That would be a series of unfortunate events. And yeah, I just like a effed up nose on a guy. Take your chewables, guys. It's going to get to be that weird time of year where everyone's getting sick again. Is it flu season? No. Is your romaine lettuce trying to kill you? Absolutely. Oh, fuck it all. Stay thick. Thickums. Okay. I'm chewing privately. And we're done. Okay. So are you all right? Do you feel all right? Are you watching the trial? Tell me everything. Thank God, Maddie Wags. Oh, and I'm sorry, good citizen Weymouth. You're sick as a dog, babe. I'm sorry. That's the worst. I don't know. Take some vitamin C and rest your body. Just go lay down. What are you doing right now? Go lay down. Okay. Thank you. Thank you. Cassie says, I'm taking the airborne and cold ease, hitting it with it all. Are you taking the cherry ones? The red cherry ones? Can't tell me shit. Delightful. Okay. You're watching. I love this. Sarah Ashley is watching the trial. So we do Cliff Notes here. We can't do the whole thing because it's It's too much. But I have watched between South Shore Hospital and Brigham and Women's, and we know the details of how the children, God rest their souls, Cora, Dawson, and baby Callum, were unalived. We know that. We have that information. It is stored in our amygdala. We are aware. We have seen all of the filings pre-trial, and for me, it's too much. So I'm not going to put it on the screen. Where I find it very interesting and where it makes sense for us to like really delve into, babes, is where Lindsay's injuries were. Seeing how, in my opinion, the difference in care received at South Shore Hospital and at Brigham and Women's when psychiatry was called, and then from today, the toxicologist and forensic scientist too, Nicholas Roberts, who looks so familiar to us because he was where Karen Reed trialing. So between him and Maureen Hartnett, it's too much. I get the ick, but there's a lot of that happening. So we're going to start with this gem of a broad. And Dr. Kelly McDonough, give us McDonough. She didn't know, or she didn't remember anything. And I was like, I'm pretty sure like I would remember a lot. Shout out to all the nurses, every nurse that testified, queen. Yeah, Dr. McDonough didn't recall much, but there was a couple of spots that I said, oh, shall we pearl it? Duh. Pearls on, clutch, clench, and kegling today. All right, so let's start with her. Add to stage. Oh, the journal entries. Yes, Kelly. We'll go into that a little bit, but not like the most because there's a lot happening here. Okay, thank you. Rhonda Hinks, I'm feeling it more and more every day, but the toxicology, you guys are going to shit when I tell you whatever. We'll go into it afterwards. Let's start with her right at 15 minutes. Here we go.
It wasn't necessary. Now, this particular patient at some point was noted to be, I think it was referred to as hypothermic. Mm-hmm. Do you recall that? Yes. Do you recall at what point in your treatment of her was that noted? Was it as she was coming into the emergency department, or did that develop while she was in the emergency department? I don't recall. What was the course of treatment for a low body temperature? We placed something called a bear hugger on them, which is a warming blanket. And can you explain to us what could cause a person's body temperature to drop to, I think it was 82.1?
All right. So this was geniusly pointed out by many a folk that the 82.5 degrees that you're seeing Lindsay Clancy, who's been out of a window on a lawn for approximately 45 minutes before she's transported to the hospital in the back of an ambulance and warmed. And she was already down to 82.5 degrees core temp. Who else was around 80 degrees? Officer John O'Keefe. Now, that was when he went to Good Samaritan on January 29th, 2022, prior to him being pronounced at the hospital at 7:50 a.m. That is wild to me that the Commonwealth of Massachusetts, in one major murder trial, wants us to believe that a decrease in body temperature took approximately 6 hours, with paramedics, including Anthony Flamati, head lead paramedic, stating that Officer John O'Keefe was still pliable, still able to move his arms and limbs, and he still had a 10% chance to live. But he only had a drop in his body temperature from 98.6 down to 80 degrees. Is Lindsay Clancy's case showing that hypothermia at the exact same time of year, right? Like we're looking at the exact same almost conditions of a January on the South Shore, like a couple of towns over. It's wild. So is it 45 minutes? Lindsay lived. Reminder, Lindsay lived. And Officer John O'Keefe succumbed to injury. Just saying. Crafter 718 says Devers 2.0. I mean, just couldn't remember a thing. She's just looking up. She's saying, no, I don't know. And I love, we'll hear Reddington in a minute be like, hey, did you review your notes? At least the other doctor, I'll find her name. No, that wasn't her. No. There was another doctor that I have. And she was a Caprio. Yeah. She at least looked at her notes, although she was slightly combative too. All right. Let us go.
There are many reasons, but it could be a metabolic disarray or exposure.
In this circumstance, did you know what the source of the drop in the body temperature was for Ms. Clancy?
No.
And do you recall how long she was in the emergency department before she was transported approximately to the Brigham?
I think it was about 4 hours.
At this time, Your Honor, I would move to enter into evidence a copy of the South Shore Hospital medical records for Lindsay Clancy from January 24th, 23 as the next exhibit.
Is it by agreement? All right. That may be admitted. Or they may be admitted.
And I would also move to enter as the next exhibit a certified copy of imaging records from the South Shore Hospital.
Can you guys hear her?
It may be admitted.
So finally, Dr. McDonough, did this defendant receive surgery at South Shore Hospital?
Not that I'm aware.
Did you observe any cuts, abrasions, or blood on the area of her head?
No.
And based on your review of those findings on the CT scans, was there any noted injury from the head CTs that you could tell?
No.
Okay, hold on. Let me see if I can fix it on my end because I heard it. Reduce background noise. Then what can I do for my guests? Maybe. No layouts. No hotkeys. Well, we know I'm not going to do this well, guys. Okay. Turn cord up. Yeah, I'm trying. How do I do that? It's all the way up over here. Shit. All right. What is a real tech? I don't even know. I'm going to leave that alone. Okay. Let's see if this helped.
And were you able, after using that bear hugger device, able to get her blood, her core body temperature back up to normal?
I don't recall.
Did you ever observe those wounds that you observed on her neck or her wrists ever start bleeding actively again?
No.
I have nothing further.
Mr. Reddington.
Morning.
So would you agree with me that when Lindsay was brought into the South Shore Hospital that she was unconscious?
I recall her eyes being open, but she was nonverbal.
Okay. So as an experienced emergency room doctor, can you tell me when someone's unconscious, what is that? What are the symptomology of it? What does that mean?
Usually means they're completely unresponsive with eyes closed.
Okay. Was she responsive?
Not verbally.
Was she responsive at all?
She was responsive to pain.
So that means that you would do something to cause pain, perhaps the bottom of the foot or whatever it is, to see if they have a reaction?
Correct.
And would you agree with me that when people even have very, very serious brain injuries, that they can respond to pain stimulation?
Hello?
Sometimes.
Sometimes. So her eyes were open. Were her pupils equal and reactive to light?
I don't recall.
You don't recall. What does it mean with PERL, pupils equal reactive to light? What does that mean?
Exactly what you just said. It means and reactive to light.
And as a doctor, what does that tell you?
It tells me that there's no significant neurologic injury.
And in this
All right. So anyway, she's saying in this part, guys, listen to me. She is saying Mr. Reddington's like, hey, was she alert? And she's like, yeah, her eyes were open. And he was like, no, dummy. How were you able to intubate her if she was alert? Because it would be so uncomfortable for a patient, which it is incredibly uncomfortable. So that was like inconsistent with an actual event that would happen at a hospital. Like, if she's not remembering correctly, or she's pretending she's not remembering correctly, in my opinion.
Case, you don't recall if her pupils were equal or reactive to light?
I don't.
Okay, we're gonna need to. All right, sorry. I'm going to need to find a different stream somehow. We'll do it. Let me come over here. I'll add this. YouTube. And then I wanted to show at 20 minutes. Oh yeah, here we go. That was it. If she's not awake, how is the intubation? All right, boom. Let's see what we got here. This is better. Okay, hold on, guys. I'm going to share this instead. Share. Oh, am I there? Oh. Oh. Okay. And then. Oh, Jesus. I'm so sorry. Split a screen. Boom. She's here. Now let's try it.
Were her pupils equal and reactive to light?
I
Better?
don't recall.
You don't recall?
I don't recall.
What does it mean with PERL, pupils equal reactive to light? What does that mean?
Exactly what you just said. It means her pupils are equal and reactive to light.
And as a doctor, what does that tell you?
It tells me that there's no significant neurologic injury.
And in this case, you don't recall if her pupils were equal
Thanks,
or
Bo.
reactive to light?
I don't.
Okay.
Well, what kind of fucking assessment did you do, doc? No offense, but as a nurse, we're checking to see if pupils are equal and reactive to light. And you didn't know that? That could have been a huge misstep at South Shore Hospital. And we find out there were several mistakes and missteps prior to her transfer to Brigham and Women.
And that's when you take the little flashlight sometimes and you put it over the eye and see if there's constriction of the pupil.
Correct.
That's what we do.
Did you do additional evaluations of her to see what her neurological function was?
She was pretty quickly intubated from what I recall. So after that, it would be difficult to assess her neurologically.
Right. Also, are you on benzos? Ma'am, did you take a benzo or a hydroxyzine or a little something? Because you're so calm. You're like a cucumber up there.
Sure. Was she on any pain medication, if you remember?
Don't remember.
You recall, did she have difficulty being intubated? I mean, would you agree with me that if you're not under some type of medication or sedation or unconscious, it hurts to be intubated, doesn't it?
It does.
We wouldn't intubate somebody without first giving them some induction medicines.
Okay. So what would the induction medicines be?
Can we shout out to the smartest and the prettiest Mr. Reddington today or yesterday?
They're not universal.
Well, what
would depend on the
What are the
case.
induction medicines that you used on Lindsay Clancy?
I don't know. I'd have to refer to my record. And also, I wasn't the one who did the intubation.
I didn't do it.
So she was intubated, had the tube coming out of her mouth. She's laying on the table, and you are continuing an assessment. You were the lead doctor in the emergency room for Lindsay Clancy, right?
I wouldn't say I was the lead. I think the trauma surgeon and I worked together.
This was the Bukkake moment of the trial thus far for me. Well, I wouldn't really say that Proctor was the lead detective. Like we're teams. We're teamsing.
Right. Her temperature, her core body temperature was 82 degrees. Is that right?
If that's what the record states, then yes.
I'm sorry?
If that's what her medical record states, then
Well,
yes.
as you sit here, you don't know what her core body temperature was?
I saw her 3 years ago. I see about 200 patients a
I'm
month.
sure you're very busy, but this.
I'm sure you're very busy. To all of our ladies and gentlemen who are nurses, who are PAs, who are NPs, who are physicians, anything. If something like this, I have about 5 real traumas. There's been about 500 sad incidences, but in almost 20 years, but 5 absolute traumas, 2 involving police and police escorts and crimes that I remember everything about. And you didn't remember not just a regular thing. Let's say somebody comes in and they're alert and oriented times 3, whatever. We have a whole kit and caboodle. But you had a patient that came in with a core body temp of 82 and you don't remember it. I don't know. Couldn't tell you. What? That seems not plausible to me, just for me.
This is a murder trial, doctor. Did you review your records and your notes?
I'm happy to look at my record if you bring it here.
Did you review your records and notes before you came in here today to testify on this case?
Sir, I did, but I don't have a photographic memory.
Did she regain consciousness at all while she was in your emergency room?
No.
Can you tell me what CSF is?
Cerebrospinal fluid?
Yeah. So what that is? CSF?
But it could be. I'm not sure in what context you're referring to it.
Well, how about if there's a massive leakage of CSF from her nose? What does that tell you as a doctor?
It could mean that there's a skull fracture.
Did you notice any clear fluid coming from her nose?
I did not.
It could mean an array of things, but that's a medical emergency. Cerebrospinal fluid is a clear liquid that comes from in between it goes in between our spinal column all the way up to your brain and rotates, and it keeps going around. It's a lube of life, okay? It's the lube of life. 30 cc's dripping out your nose is mayday. Mayday spinal cord injury.
Is that something you would look for?
Yes.
How quickly do you get the results of the x-rays when you're in the emergency room?
Well, these were CT scans, but fairly quickly in a trauma.
I'm sorry, CT scans, x-rays. So you had CT scans that were able to show you the damage to her neck and upper chest, is that right?
Yes.
And what did those CT scans show you?
Well, what I remember is a thoracic spine injury.
And when you say a thoracic spine injury, would you agree that top part of your neck, your throat area would be cervical, right?
Correct.
And that's when the numbers go C1, 2, or whatever they are. That would be the actual vertebrae in the cervical area of the upper body, correct?
Correct.
Yes, the cervical spine.
Okay. And then below the cervical spine would be the thoracic spine. Is that correct?
Correct.
And the thoracic spine would be, and sometimes they're delineated as T1, T2, meaning thoracic 1, thoracic 2, all the way down to what, 5 or 6?
12.
There's 12. Thank you so much, Esty. I just wanted to bop in and say, sup, lovies, excuse the rude interruption. If you live in or around Boston and are free tomorrow night, James Jackson and I are doing a Red Sox tickets giveaway tonight at 6 p.m. Join us or not. On your mark, get set just for you, boo. We'll be done at 6. If they say not. Also, let's do a little, Esty, hope you're doing well, babe. Thank you so much for joining. Let's say, for example, we're going to do a little bit of an anatomy and physiology lesson. I know it's a pain in the ass, but it's going to make sense, guys. Okay. So, and that's what I am, a pain in the ass. So if you're looking at your C spine, there's 7, right? You have C1 through 7. You think head and neck. Then you go thoracic. That's your entire, from the top of your back all the way to right before your sacral spine. And there's 12. So you think of it as 7 o'clock, you have breakfast, right? Your cervical spine. Then you have 12 thoracic. And then at your sacral for supper, what time do you have supper at? 5 o'clock. We have 5, lumbar. L1, L2, L3, L4, L5, S1, here we go. But I'm just saying these are ways to remember it. And it's huge because when we see the injuries and the sustained effects that of the aftermath and not paraplegia, she's paralyzed, from waist down, she has movement of her arms and she's able to speak and breathe on her own. So she's not a quadriplegic, she's a paraplegic. And there is something to be known about where her injury is. So she has a C spine injury, which I still don't have the level, but she also has a T5 and T6, which is right in the mid back. Think right between your shoulders, right? And that would make sense that she had issues with her breathing. That makes sense. And this was a transection. This is an injury that is so egregious that her spinal column, that is usually like this, disjointed like that, severed. So when the Commonwealth wants to tell us that this was, she hop skipped and just gingerly dangled from her second story, I'm going to need them and you know, Buckingham and her buck and bows. I'm going to need you to find one of those. Okay. Thank you so much. Next.
I'm sorry?
12.
12. So when you looked at, and the lower portion would be the lumbar, is that right?
Correct.
Now, when you looked at the CAT scans, did you determine the extent of the injury to the spinal cord?
I could determine the extent of the injury to the bony thoracic spine.
Okay, what was that?
I don't recall exactly the level. I would have to look at the report.
What does that mean? The level of the T?
You're coming.
Was her cervical spine?
You're here to testify at a murder trial, and you like didn't review where her injuries was. This is mind blowing.
Spine injured?
I don't recall. I'd have to look at the report.
Were you aware that her thyroid was crushed?
I don't recall.
Do you know that her cervical spine vertebrae was fractured, destroyed?
I don't recall.
Doesn't that
I don't
control a person's breathing? Does that
Sure
have
does.
anything to do with breathing?
Thanks,
It
Mr.
can.
Reddington.
What do you remember?
Do you remember
about
anything,
looking at
Vic?
the damage to the spinal cord depicted on the
No offense.
CAT scan?
What sticks out most in my mind is her thoracic injury.
Okay, and what was the thoracic injury?
I don't recall the exact level,
What does it mean by effect level?
the exact level.
I'm sorry. Were you aware that there was a complete transection of the spinal cord on T5 and T6?
I'm sure I was aware at the time, yes.
Okay, and just can you tell me what does it mean when it says a complete transection of the spinal
What's that
cord at
mean?
a particular, apparently that would be at thoracic 5 and thoracic 6, right?
Mhm.
What does that mean with a complete transection?
It means the bones are no longer one on top of the other. They're moved apart.
Were you aware that there was a significant edema noted in her chest?
If that's what the report says.
Okay, and what is edema?
Swelling.
And does it also refer to fluid?
It can.
Did it refer to fluid in this case?
I'm not sure. I would have to read the report.
Beyond. Okay. So this is beyond. We also find out, and I don't remember if it is from her, but we've basically seen enough. She doesn't recall anything. Okay. Reddington takes her to town, but we learn that she is sent over via med flight helicopter to Brigham and Women's. South Shore Hospital is a level 2 trauma. Know this, babes, because Brigham, Mass General, they are all, even Beth Israel Deaconess, they are all level 1 trauma centers. So this hospital was not equipped to handle or provide surgical intervention for Lindsay Clancy because she was too critically injured. They telephoned, okay, her, Dr. Kelly and Dr. Capino, they end up doing a little ring-a-ling over to neurosurgery. The neurosurgeon says, hey, bitch, I'm going to need you to med flight her because this is beyond our scope. She needs a higher level of care. That's why she goes into Boston. Yet the Commonwealth is still going to push the narrative that she really wasn't that injured at all. Okay, look at her. Look at her. She's fine. She's sitting in that chair because she's lazy. All right, next. We'll listen to her for one more second.
So in addition to the edema that was noted, was there edema noted around C7, T1, T2, T3 to T4?
Mm-hmm.
Again, I would have to have the report in front of me.
When you noted her base temperature as being 82 degrees, what does that tell you as a doctor?
It means that her body temperature is lower than normal.
And what is normal?
98.6.
And if a person
What is normal?
goes from 98.6 to 82 degrees before you place her in the bear hugger, What does that tell you? Does that affect the body at all?
Yes, the body works ideally at 98.6. So anything outside of that range, not ideal.
To what effect, as a doctor? What effect, if any, on the body if a person has an 82 degrees base temperature?
What does
The
that
list
mean?
of things that could go awry is quite long.
Can you give me an idea, maybe the top three?
She could have a metabolic derangement,
What's a metabolic derangement?
meaning her body wouldn't be processing things the way that it was before. Her cells are not working the way that they should because it's too cold.
Would you agree with
Or organ failure.
me that when you were looking at the injuries to the wrist and to the both wrists, actually, you noted lacerations in the volar aspect of the wrist?
Yes,
What is a volar? What does that mean?
it's the anterior aspect of it.
Interior? Okay, thank you. Would you agree that on both wrists there was deep laceration?
I wouldn't characterize it.
And when you made reference to her being transferred to a tertiary care center, what does that mean?
It means that it's a hospital that has more services and specialized care than we do at our hospital.
Interesting that she says that I wouldn't consider them deep, because we find out today, and I'm sorry that I'm doing spoiler alerts, we'll listen to this testimony too, that she was sutured. When I saw the pictures, and I'm not going to show you guys because, you know, facts matter, don't be graphic. You can see that there are superficial lacerations to her bilateral wrists, meaning both of Lindsay's wrists, but there was one on each wrist that I said, that's not superficial. That's not superficial. And if you are suturing by nature, it is not superficial. Do you hear me? So why is South Shore, and even at, you know, Brigham and Women's, from some providers will be like, yeah, it was just superficial. But you had a PA come in and provide care management. And if you had to stitch, then that means it is not able to heal independently. It needed extra help. It needed secondary, like, approximation.
Now, when she was at the South Shore Hospital, counsel asked you about whether or not you noted any injuries to her head. You did not notice any bleeding or scrapes or bruises of that nature, right?
Not that I recall.
Did you notice any injuries to her lower body, her legs, her feet, let's say her feet or her buttocks?
I don't recall.
Oh, okay. She's an angel. She's just a gem. All right. Now am I going to get rid of her? Remove. All right. Stay with me. Now we're going to Dr. Caprio. Now, this better mother, I'm going to be pissed if I downloaded all of them and they're going to have no volume. It'll make me sad. Let me go to downloads. All right, this is better. Oh. Good. Sorry. Then we're gonna, guys, I'm gonna get better at this in the year of our Lord 2029. Okay. Big and go.
Name?
Christina Carpio.
And can you spell your last name for the record?
C-A-R-P as in Peter, I-O.
And what do you do for work?
I am a general surgeon trained in trauma and critical care.
And where do you currently work?
I'm hired by Brigham, but I work at South Shore Hospital.
Can you tell us a little bit about your educational background?
I completed medical school and then went to general surgery residency for 5 years at Columbia Presbyterian.
Highly qualified. We'll say that. Okay. So Caprio also was hired. She technically works for the Brigham, but she's contracted at South Shore Hospital. Happens a lot with general surgeons. I'm going to minute 6.
A completed angiogram of the neck area at South Shore Hospital?
The images were done. The report was completed. I don't know the timeline of when the report came in compared to when the patient was transferred.
So as far as your initial assessment in that trauma assessment period, or that wasn't information you had available to you about the neck findings, correct?
The angio neck findings, correct.
Okay. And that's different from other CT scans on the cervical.
Shit, I meant to go back. Sorry, my bad.
The head CT with contrast was what we call an angiogram head and neck. So it's ordered in 2 parts and has 2 reports.
They did a full entire CT scan on Lindsay's body from head and neck. They did trunk and then they did abdominal pelvis. And that is in order to see all the things. They are looking critical care. She comes in level 1 to South Shore, which is the highest that they can handle. They realize quickly within a couple hours, hey, out of our league. But I want you to hear, because the prosecutor, our Buck and Bow, she is going to keep telling us that there was no injuries that South Shore needed to address in order to stabilize Lindsay to get her to the next hospital. And that is completely counterintuitive to anyone being transferred. Anyone with a brain knows that. If she didn't need any stabilizing interventions, then why the fuck would she have been transferred? That doesn't even make sense. And we find out that a lot of things ended up going absolutely haywire as soon as Lindsay arrives to Brigham and Women's.
At the time of the documentation that was performed, we had the report back on the head section, but the neck was not completed at that time.
Okay. Was there eventually a completed angiogram of the neck area at South Shore Hospital?
The images were done, the report was completed. I don't know the timeline of when the report came in compared to when the patient was transferred.
So as far as your initial assessment in that trauma assessment period, or that wasn't information you had available to you about the neck findings, correct?
The angio neck findings, correct.
Okay. And that's different from other CT scans on the cervical spine and other areas of the spine. Is that fair to say?
Yes, that's correct.
As the trauma surgeon evaluating this case, did you identify that there were some serious spinal injuries to the cervical and thoracic areas?
Yes.
Did any of those require you to intervene with surgical intervention?
No.
Do you recall making note that while in the emergency department, the patient became hypertensive and that she was identified as being hypothermic to 82.1 degrees?
I remember that she was hypothermic when I reviewed my documentation. The two numbers I saw in my note were normal values of blood pressure, not high values, not hypertension.
Okay. If I may approach you just with one of the pages from the notes, read your review.
This was a bazinga moment. A bazinga moment. Got what the buck right off of her high horse. Knock a couple bows off her head. Oh, because she wasn't hypertensive. She was hypotensive. Because she had severe...
She was hypotensive, which means low blood pressure, different from hypertension, which is high blood pressure.
Okay,
yeah,
sorry.
Yeah, no, not at all.
But as far as
Mazel.
That you recall that she was at a very low core body temperature.
Yes, that's correct.
And do you know what was done to raise her body temperature?
We raise the temperature in the trauma room to be able to raise her body temperature. That's usually our first line of intervention.
And do you also have available to you at the South Shore Hospital what's called a bear hugger or some sort of blanket or wrappings that you can wrap around an individual to try to get their body temperature up?
Yes, we have that.
And at some point, her body temperature did come up to 95.2 degrees, correct?
Yes.
And based on your observations of...
Allegedly. Oh, yeah. Oh, it came up so many degrees. Wow, that's wonderful. P.S. 95 is still hypothermic. But let's hear what Kevin Reddington says, because this was a little jaw-dropping to me as well.
Of her, did anything change about those lacerations that you observed once her body temperature was up that warranted some surgical intervention of those injuries?
No.
What was the ultimate recommendation for the care of this patient?
She had complex fractures in her spine at the thoracic level. We conferred with our neurosurgery colleague who was on call, who recommended transfer to a tertiary hospital.
And so where did this patient go?
Brigham.
She was fine. She's a faker. We just sent her to a level 1 trauma. Don't make it weird.
Now, you identified that your hospital is a level 2 trauma, correct?
Yes.
After fully reviewing this patient, did you agree that this was a level 1 trauma situation?
Yes.
Are you able to do surgical intervention for these particular injuries that you observed on this patient at South Shore Hospital?
The spinal injuries require input from our neurosurgical team.
And there was none available to you at the South Shore Hospital?
We did contact the on-call neurosurgeon. Because we are a level 2 trauma center, they are not required to be physically present in the hospital, but they were immediately available and they can remotely review images.
That's terrifying. That's terrifying to think that our level 2 hospitals don't have a neurosurgeon on staff in the hospital. Like, it's great that you can page them and you can do a little beeperino. Let's zoom him in. But like, oh, weird.
So I guess my question is, why didn't you do any surgeries regarding those injuries at South Shore Hospital? Why did you recommend the care to a tertiary hospital?
The complex level of spinal injuries was deemed necessary for transfer by our neurosurgery colleague.
Okay, thank you.
Reddington.
Mr. Reddington.
Good morning.
Oh, he's funny.
Just a few questions. So South Shore Hospital, and you made reference to as being a trauma hospital, and the injuries suffered by Lindsay were at level 1. Is that what it was?
Yes, that's correct.
That would be the highest level. Is that right?
Yes.
As far as risk or concern of the person's safety and health and survival.
Yes.
What time, if you remember, what time approximately was she admitted to South Shore Hospital?
The word admission means that she would have remained there as a patient, so she was never formally admitted.
Okay.
For the time that she was brought in by EMS, I would have to refer to that information from the record.
Do you have an idea as to how long she was at your hospital?
Likely several hours, but again, I would have to see the specifics in the charts of there's documentation with EMS for arrival and for when transfer occurred to Brigham.
Okay. And at some point, it was decided that she would be transferred to Boston, right?
Yes.
Brigham and Women's Hospital.
Yes.
And it was decided by someone that they weren't going to put her in an ambulance for that transport, right?
I would have to look at the record for what was the method of transfer to Brigham.
Do you know how she was transferred? By helicopter? Med-flight?
I don't know, because MedFlight can also, MedFlight covers 2 modes of transportation, MedFlight ambulance and MedFlight helicopter.
Do you know that she was Med-flight helicopter to Boston?
I don't know that.
And the time that she left was after you all had provided the treatment that you were able to provide to Lindsay as a patient, right?
Yes.
And you reached the end of your rope. She had to be transferred because she needed immediate high-level medical care, right?
She needed higher level of care. Yes.
Higher level of care. And as a result, she was then brought to Brigham and Women's Hospital. Now, the treatment that you had given would include raising her apparently temperature.
This is it. This is a magic moment. I know that the jury had to pick up on it.
I guess, because she came in at a low temperature, right?
Yes.
And did you use IV fluids?
I would have to check the record, but that is a common intervention.
So your memory would be that you believe that you used IV fluids, but you'd have to have me get out of the...
Remember, they did that with Officer John O'Keefe too. Is like a warming fluids. You're trying to raise a temperature in an appropriate fashion. You don't want to shock the system additionally, but there are warming fluids. There's the bear hugger. There's different interventions in which we use to treat hypothermia.
Box and check the record to ask that question, right?
Yes, correct.
Okay. It didn't really work out very well, though, did it? Because you know that when she was brought to Boston, after all of the time that she was treated at your hospital, she was still core temperature of 82 when she hit Brigham and Women's.
No, allow it if she knows.
I did not look at the medical record from another institution. I only reviewed my note from South Shore Hospital.
Oh, I'm sorry. Didn't we just have, Miss Bose a lot? Bozo, I don't know. She gets up and says, well, you raised Lindsay's core body temperature from 82 to 95, which is still hypothermic. And we find out that upon admission at Brigham and Women's, Lindsay was still 82 degrees, or that's what she registered. And there's no fucking way, I'm telling you right now, babes, that in that med flight, that they didn't have her, she was in a little aluminum foil, okay? She looked like I know how the transport looked, and she was in the most warming during that transport.
Did you know that your patient had coded shortly after being brought to Brigham and Women's Hospital?
No.
Did you know that she had to have massive transfusions right after being brought to the hospital in Boston?
No.
Did anybody in South Shore Hospital make a determination that she had lost a lot of blood?
What? Stop it. You stop it. You didn't evaluate her for blood loss? When all you asses keep saying, oh, yes, she had such superficial cuts, everything's superficial. Oh, thanks. Really? Really? Because she needed massive and multiple blood transfusions. And she coded shortly after arrival at Brigham and Women's.
There was the EMS report did not share that there was a large volume of blood at the scene. She was
If anyone has seen this trial, you know there was a large amount of blood at the scene, all the fuck over the place.
evaluated to her part of her CAT scans also help us evaluate for intra-abdominal blood loss.
Okay, so when you raise the issue of the EMS, that would be the
No, Morgan. No, sweet baby angel. This is a lack of knowledge. And I mean, like, I get it that you see so many patients, but these are the ones that would stick with you. I don't know. Just for me. And also, you have the ability to review the chart and review all of your documentation prior to testifying. It is wild. However, someone made an incredible comment in the chat that said, purposely being vague. Why? Because we have upcoming civil suits. So you don't want to over explain, but saying I don't recall when you can actually point at the civil suit and the trial, they will end up pointing to specific documentation and words said. What did you write? If you didn't document it, you didn't do it. 101.
ambulance, right?
Yes.
And their report, their run sheet, they prepare, right? That's what you're talking about, right?
There's verbal report from EMS when a patient is brought in and also the run sheet of the details.
Okay. And when the people from the EMS came in, did they speak to you about the verbal report?
They address the entire room, so all the staff in the room is available to hear the details.
They told all
and
of us.
You're able to look at the run sheet, correct?
No, the run sheet is not always immediately available.
So did the EMTs, to your knowledge, as a treating surgeon, physician in the trauma center, tell you that there was blood loss?
Not to my recollection.
Did anyone tell you that at the scene where she was being treated after coming out of the window and striking the ground, that there was blood in the snow and on the leaves and in the grass?
I don't know.
I cannot recall if they commented on that.
Is that important for you to know if there's blood loss on a patient?
If there is a large volume of blood loss, yes, the EMS will routinely comment on the patient being found.
No, but that's the EMS. You're the surgeon, right?
That is correct, sir. Yes.
Yeah, and one of the things would be blood pressure, right? What the person's blood pressure is, correct?
Yes.
And she had,
And she was hypotensive at South Shore. So she's showing you that she doesn't have enough pressure to pump because she has a potential root cause is blood loss. What was her H&H? What did her labs look like? We talked an awful lot about CTs. What did her labs look like, lady?
you understand your testimony correctly, low blood pressure.
She initially, when she came in, the note has a normal blood pressure, and then after intubation, her blood pressure dropped.
Okay. Do you know
even more
caused the blood
indicative.
pressure to drop?
There were several factors at play. As we discovered from her CAT scan, she had an injury to her spinal cord in the thoracic region that very commonly causes issues with maintaining your blood pressure.
And do you know what her blood pressure was? I mean, if you don't, that's fine. You need the records.
Blood pressure at which point?
At the point I'm asking you about when you noted that she had low blood pressure.
No, I don't remember how hypotensive she was, no.
As far as being hypertensive, did you know that when she finally hit the Boston hospital that she had massive transfusion of blood?
And she's saying, like, that's not our protocol because that would be the protocol for Brigham and Women. So they don't call it that. But maniacal miss, interesting question. A lot of people have said this. Do you think maybe she didn't get cared for till she was in the ICU at Brigham and Women's because of the unaliving of the little ones? They seemed very disinterested in her or her care. I don't know. And like, I can't comment on state of mind, but what I can say is that it seems like they missed an awful lot. And that is one of two things: laziness, negligence, malfeasance. That's what you got. And you see her come in the condition in which she was. You received those imaging results, consult telephonically with a neurosurgeon, and then you let her go. It is very possible that had that neurosurgeon not said transfer immediately, right, and started the whole process, that Lindsay Clancy would not be here. Would she maybe be happier in life that she is not on this earth anymore? Maybe. But these physicians really dropped a ball, in my opinion, in what they're stating on the stand.
I thought I asked and answered.
Oh, did you?
You asked me before and I answered that no, I did not know that.
Okay. So how about, did you know that they introduced pleural tubes in both sides of her chest and removed
chest tubes,
many cc's of blood from both the
hundreds
right and left
of
pleural
cc's.
cavity?
No, I just object to the line of question. The witness has already indicated she hasn't reviewed those records. She's not aware of what happened at the Brigham. Go through each and every injury is not us.
No, she can answer that.
No, I do not know that.
P.S. They can place at a level 2 trauma, they could place chest tubes. So what was happening?
About the patient when she was not at South Shore Hospital.
How about the superficial cuts that you were talking about? Would you suggest or would you agree that on the right ulnar area and the left ulnar area of the upper extremities, right and left, that there were a deep cut noted in the skin?
The notes about her wrist injuries said that it was through the skin with exposed fat, but there was no exposed muscle or tendon. So
Okay.
those are more superficial.
So,
Okay, if you have adipose showing, they're saying that that would not be considered a deep laceration or a deep cut. And I disagree. We're going to find out from the provider from today, P.A. Eaton Negri. He says that the lacerations to her bilateral upper extremities, he repaired 2 of several. There was no active bleeding at the time he did this on the 25th of January, 2023. I lied. They were dressed and covered and treated by other providers previously, but there was a severe laceration and it was deep enough to require repair, 3 centimeters deep. Think about your wrist. Okay. That's not like your abdomen. If you have 3 centimeters deep, your wrist has such less surface area. That's deep, and it matters the location, you know?
you would not agree that they were deep cuts on both ends? You wouldn't agree with that?
No, I would not.
And again, you're not aware of anything that was diagnosed in Brigham and Women's Hospital, right?
That is correct.
As far as the injury to her spine, what kind of injury was it? Do you remember?
It was at thoracic level T5, T6.
And what type of injury was there to the spine?
The report said that the stability of this, the pattern of it indicated that there was instability of the spine, which is why we conferred with a neurosurgeon.
Right. And nothing much came out of that either, as far as conferring with the neurosurgeon, right?
I'm not sure what you mean by nothing much came
Well,
of
you
that.
didn't show up to come to the hospital, right?
We didn't. I'm not sure.
Okay, the spine was.
She was like, duh, Wait, what do you mean nothing much came out of it? We decided to transfer her. But yeah, that was a dig at your hospital system. That was a dig at the fact that when you were called, that you should have responded to the hospital if you were an on-call neurosurge. And yes, at 350 P8 SP8, one of the lacerations was over 1.25 inches deep. We use actually for all wound measurement in healthcare, we use centimeters. So that's not weird, but for a jury, like that is very important. How deep is our wrist? Like the whole thing, what, 3 inches? 3, and especially, well, okay, all right, I'm a thickums. Lindsay is probably 2.5, 2 3/4 for like your depth. And you're telling me you didn't hit a tendon? I call bullshit.
Transected at T5, T6, right?
The team, or rather the input you would need for further commentary on the spine would be a neurosurgery team. I am not a neurosurgeon. I am a general surgeon.
So you're not aware of the transection. You know what a transection is, don't you?
Yes.
Okay. And on your CAT scans or on your pictures that you were describing for the jury with no problem for the DA, did you notice that the spine was transected at T5 and T6?
There was compression of the bones. I would have to specifically look at the report to see if it used the word transection.
Okay, how about
Well, know why? Because she doesn't read the report. She doesn't. Radiology did.
the thyroid? Did you notice anything about a thyroid?
It said that there was edema at the thyroid, concern for contusion or laceration.
And that's the extent of your knowledge. You don't know whether or not the thyroid was destroyed or anything, do you?
Correct.
Okay. How about her ribs? You notice that some of her ribs were broken.
I would have to look at her.
Broken ribs on top of it. Thyroid. macerated.
CAT scan report again.
Yeah. So coming in here today, you're not aware whether or not she had broken ribs because you haven't been able to look at your records. Is that right?
I did review my records. I would have to specifically state into the record what was the injuries. I would be happy to read from my note, which I know is part of the evidence.
Yeah. So who is it that decides that a patient is going to be med flighted into Boston from South Shore Hospital?
Some of it depends on the level of injury and the transport teams that are available at that moment. Sometimes a med flight ambulance is faster. Sometimes med flight is available. It all depends on the available resources at the time of the event.
So what I asked you is who decides whether or not somebody's getting med flighted out of South Shore Hospital?
It is collaborative between what resources are available for us to transport the patient. The decision to transfer the patient is made between the emergency room team and the trauma team. And
Thank you. Thank you, Doc. All right. So those were our two doctors from South Shore. Now we're going to go into nurses from Brigham and Women's. Shout out. Love our nurses. Hold on. Am I removing it? No. Am I? No. Stop sharing it. There we go. Then I'm going to do this. Boop, 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 boop. Nope. Okay. Downloads. All right, Kimberly. Now let's get this lovely little. Hi, ICU Nurse Collins. Step on up. Look at this bun. Love it. She means business. Buns mean business.
In January of 2023, what unit were you working on at the Brigham?
The trauma surgical ICU.
All right. Nurse Collins. She's been a nurse for 11 years. She's been at Brigham and Women's for 8 years. She's a trauma surgical ICU nurse. She works 7A to 7P. Thank you, Queen.
What does that mean for you as the nurse if she's on the one?
Debated when she arrived.
And were you with her the entire day of the 25th from that 7 a.m. to 7 p.m. shift?
Yes.
And was she on what's called a one-to-one during that day?
Yes.
And what does that mean for you as the nurse if she's on the one-to-one?
She was one-to-one nursing per our ratios because of how critically ill she was.
Boom.
And so you were there pretty much the entire time?
Correct.
Were there any other people there other than the medical staff and yourself treating her? Were there any other people there?
There were officers, police officers.
And they were outside the room?
Correct.
Had you taken over care of this patient from another nurse on the night shift?
Yes.
And who was that?
Rochelle.
And you are familiar with Rochelle? You've worked with her before?
Yes, I have.
And were you advised that over the course
See the little smile? She's like, me and Rochelle go way back.
of the night shift that this patient had coded?
I was.
And when you came on shift in the morning, because of what had happened overnight, were you aware that she was sent for additional CT scans?
We went for CT imaging in the morning when I got there because she was not stable overnight.
Okay. And you said she was intubated, correct?
Correct.
How about, was she responsive during that first day that you encountered her?
The first shift that I had her, we were focused on her injuries and keeping her sedated. So the interactions, responses were minimal, but that was intentional as she was, again, like I said, so critically ill.
Incredible. Now let's go back and think about our Dr. Kelly McDonough, who was like, yeah, she was alert and looking, and she was awake. And, you know, I was able to intubate her, no problem, no flailing, no resistance when any human would have a reaction to a tube going directly down your throat. And meanwhile, you needed it for what? Your ABCs, airway, breathing, circulation. We don't give a fuck about anything else in a medical, like in a critical event.
And so you also said that she was sedated for the majority of that day, correct?
Yes.
And is that something that often happens when a person is intubated, that they're sedated?
It is.
Yeah.
What happens if an individual isn't under sedation and they're intubated?
It is patient dependent, but
Oh, I'm sorry, Nancy. Nancy Daly, are you telling me that I must have not seen that at the end? It was Dr. Caprio? She was a hostile witness? Oh, thank you. She was a little combative.
majority of patients are not able to tolerate the breathing tube and it's uncomfortable. So we give them medications to keep them as comfortable in tolerating the breathing tube as possible.
Yes.
Now, you mentioned treating injuries and keeping the patient stable as your primary goal, correct?
Keep them alive.
Were you able to make note of some physical injuries that the patient had?
Yes.
And were there some obvious injuries that you could observe?
Yes.
To her neck and wrist area?
Correct.
May I approach the witness? Show you 2 photographs, okay? Does that look familiar to you?
Mm-hmm.
Do you know
Yeah.
that to be the patient, Lindsay Clancy?
I do.
And fair to say she has a breathing tube?
She does.
And then the second one, again, just the other side of her neck. Is that familiar to you?
Yes.
Are these very inaccurate representations of the neck injury that you observed for this particular patient?
To the best of my memory, yes.
They may be admitted.
Oh, no. No,
She's on
no.
her neck.
No, sorry.
Now, you treated her on the 25th, right? And did you treat her on the 26th? To your best of your memory?
I would have to go back and look.
I don't have a problem if she leads her records. Yes.
As far as January 26th on that 7 a.m. to 7 p.m. shift, do you recall making notes that the patient required additional sedation due to the tube intolerance?
Yes.
Okay. And that she was started on low dose of propofol?
That is correct.
And that in the afternoon that she had
Think propofol, you think Michael Jackson, but low dose.
the chest tubes, and you kind of check those chest tubes to, it says, interval CXR looked okay with chest tubes to water seal.
Yes, that's correct.
And so she had previously been given chest tubes, and your role was just to kind of make sure that everything was fine.
They place bilateral chest tubes, and monitoring those is a part of my responsibilities in the ICU. And we were concerned for her respiratory status. So that is why I made a note of it.
Okay.
Because I documented it, because I did it. She needed the chest tubes that were draining actively. Because South Shore Hospital didn't do anything. Thank you.
And as far as the injuries that were a part of your assessment of her, fair to say on January 29th, you also were treating her that day from 7 a.m. to 7 p.m. and you made a note where you identified injuries, right?
Correct.
And those injuries would have been things that were reported to you based on a doctor's review of labs and images and that kind of thing, correct?
Yes.
You don't make your own assessment about thoracic injuries or cervical injuries.
I do not diagnose.
Oh, know why? Because she's a registered nurse. Thank you. Thank you for showing up today to the court of medical terminology. I don't diagnose anything, but I will assess all of it.
Also on the 29th or the 28th into the 29th, that is at that point when the patient was extubated, correct?
Correct.
Do you recall making observations of the patient when after she was extubated?
She was not extubated on my shift. I was there the following day.
Okay. Did you note how her demeanor, her presentation the next day?
I did.
And fair to say you noted increased confusion, agitation, and picking at lines and drains, correct?
That's correct.
And fair to say the patient had to be restrained because of the activity.
That is correct.
Sad, but kind of typical when you're extubated with those symptoms of like trying to remove everything. As soon as when you're coming to, guys, and you're coming out of something like being sedated for extubation, you're so thirsty. All you want to do is like drink all of the water in the world. You want to be a camel. You're like, fill my friggin' humps. Okay. You're like, God damn it. I have never been more thirsty in my life. Sorry, Tiny Mary and Tiny Jesus and the boom. but like that's what you care about. Then you're like waking up, you're coming to, you're in an ICU fucking delirium, and you're like, oh my God, I've got shit. She's got blood hanging from her, right? Because she's getting blood product. She has all of the lines in her, and you become like wackadoo. We'll find out additionally that she also had visual hallucination, which is not a normal side effect. ICU delirium is after extubation, but not what Lindsay actually had, in my opinion.
Is that something that you often see when patients come out of intubation, that when they're extubated, that they exhibit signs of confusion or delirium?
Yes, it's called ICU delirium.
Yes.
And over the course of the next few days, in your interactions with her, did you see that delirium decline or decrease?
Yes, it was
Dissipate.
a multimodal approach to manage the delirium, agitation, and it did get better and it did improve.
And fair to say, during the time that you were treating this particular patient, there was also sleep issues that were part of the treatment plan.
That is correct.
And on January 29th and January 30th.
Well, I'll be dipped in shit. I want to take 1 minute for all the people. Oh, I won't do you dirty like that. Sorry, Nurse Collins. You beautiful queen. Listen to me. There was still sleep issues while in the IC fucking U. Everybody put that into your caps and say, oh, babe, you were on propofol. Babe, you were on every other sedative humanly possible. You come out, you're in a delirium trying to rip all your shit out. And the second that you are not sedated and under, you can't sleep. And they have to try multiple medications. They have to consult psych, and you're still not sleeping. And yet Lindsay was at home and not sleeping. And on the amount of Seroquel, which we'll go into toxicology later, unbelievable that they didn't see that this was a whirling dervish and about to be a shitstorm of epic proportion, in my opinion.
2023. Were you present when the psych consult team came in to speak with the defendant?
Yes, I was.
What was the purpose of you being present?
The purpose is we had consulted the psychiatry team to evaluate and determine capacity. And my role is as the ICU nurse is advocacy on behalf of the patient and to alert the providers if there's any changes in the mental status.
Now, when they came in and you said advocate for their position, you're aware that the patient was looking to change her healthcare proxy, correct?
The patient was changing her healthcare proxy. That is correct.
And that there has to be an evaluation to determine whether she's of a particular mental status and medically able to make that decision on her own. Is that fair to say?
Yeah.
If she has capacity, yes. Now, Tammy Glasson happened Simpsons. 4941, her babies are sleeping forever. I 100% understand that. I 100% understand the gravitas and the severity of this case. I'm just looking at it from a medical standpoint. I'm looking at it from a legal standpoint, and it's so chilling and tragic. And that those babies are at the forefront of my mind at all times when I talk about it. Just hope you know that.
Yes.
Okay. And do you recall who was present other than yourself and the psych doctors, the doctors from the psychiatric unit?
There was the social worker, myself, and her lawyer was present.
Had you been present when a lawyer or somebody else was with her prior to this consult?
No.
And fair to say, you were made aware very early on that there was a particular group of people that would be having access to this individual, correct?
Can you clarify?
Well, is it fair to say that the treatment team was kept small on purpose? Meaning the same people were coming in and being the nurse, day and night staff. There was limited access. Is that fair to say?
It was kept to a smaller team, but that was also protection of privacy for the patient.
And during the course of time when she's on the ICU, which is between the 24th to February 3rd, there's always law enforcement posted outside the room, correct?
Yes, and it was because she was.
Well, I'm just asking you if there were law enforcement.
There was.
Do you recall having to check with the nursing director and the legal team at the hospital to make sure that it was permissible to allow anyone in besides medical staff?
Yes, that's standard protocol.
And
Talk
when
to
she
my
was
girl like that.
transferred off of your unit on February 3rd, did you have any further contact with her?
I did not.
Nothing further, thank you.
All right. Attorney Reddington.
I think.
Dear God, Zach.
How many years you been a nurse?
11.
And you obviously take that position as very serious, and your concern is to protect your patient. Is that right?
That is.
Advocate. Yep.
You made reference to the fact that she was changing her documents as far as healthcare proxy.
Yes.
Did you know anything? Did you know who she was changing it from? Her husband to her mother and father, or did you know anything about the specifics?
She was changing it from Patrick to her parents.
Thank you. And finally, what is a DNR?
DNR means do not resuscitate.
Do you know what her DNR was?
Her code status was full at the time that I took care of her.
Do you recall that she had indicated repeatedly that she wanted a DNR, that she did not want to be resuscitated if emergency arose?
I was not privy to that knowledge.
Okay, but that's noted in the medical record. It would be noted in the records, right?
It would be, yes.
Thank you very much.
Oh, get that last word in, Mr. Reddington. 10 out of 10. Zach wants to legalize propofol, and I want to legalize the fact that we take care of all of our patients. It doesn't matter what you have done. It doesn't matter your creed, your race, your religion. It is our job to advocate. It is our job to keep you alive, and good nurses and good doctors will do that. The legal system needs to take its own action and take its own course, and it is not our job to judge. It is our job to heal. And I praise you, Megan. Praise be, Megan. All right, now we are going to, is she? I'm going to stop sharing that. We're going to find our next nurse, our next queen of the day. My 27-yearer, I'm right in between them. So Megan's been a nurse for 11 years. Our next is nurse Rochelle, and she has been a nurse for 27 years. And I've been a nurse for almost 27, 19 years. I've been a nurse. Psychotic. Find it. Okay. Where's my girl? Tell me. What happened to you? Isn't she gonna know it all? Oh. Oh no. It's too low. This is good. I'm glad I did this, guys. Hold, please. I'll have to find another version. All right. Stop sharing this, maybe. Or get out. Back it up. All right. Nope. X. Rochelle. Where are you? Rochelle. Testimony. God, I should have looked at all that. I apologize. Here we go. Let's try this one on for size. Can I hear you?
And what were your
Better.
responsibilities as the nurse assigned to her care on that first night?
First night, she was intubated. She came to be intubated. We had to maintain pressure at a certain.
How did she come to your unit
Here it
at the
is.
Brigham?
She came from the emergency room, went to MRI, then came to the ICU to me.
And were you aware that she had been seen at a local hospital?
Yes.
In Weymouth, the South Shore Hospital?
South Shore.
While you were treating her on that first night, were you the main nurse assigned to her care?
Yes.
And what were your responsibilities as the nurse assigned to her care on that first night?
First night, she was intubated, came to me intubated. We had to maintain her blood pressure at a certain number, just care, regular nursing care.
Okay, and were you aware that she was on what's called a 1-to-1?
Yes.
What does that mean?
That means patient usually can't be left alone, and also depending, you always have to have somebody outside the room with sort of monitor the patient.
And is that because that patient has been identified as a potential suicide risk?
Yes.
Okay.
Or critically injured, but that's okay.
Now, on that, the 24th into the early morning hours of the 25th, was there a particular event that you were witness to for this particular patient?
She coded.
What does that mean?
Means her blood pressure dropped for her. It meant her blood pressure dropped and it wasn't sustainable with life.
So what did you do when her blood pressure fell and she coded?
We started CPR, we did compressions.
And this event occurred approximately at 3:30 in the morning, correct?
She's transported from South Shore Hospital. She quite literally arrives, goes to MRI, comes up. She's introduced on the floor to Nurse Rochelle, like she's given a report. And that within that same shift, before 7 in the morning, she codes because she's hypotensive. And when your blood pressure drops, guys, and you're like 60 over nothing, I don't know exactly what her blood pressure was, but for her to code, it's inconsistent with sustainability of life. So we have to do compressions. We have to pump the blood for you. We have to breathe for you until we get a rhythm.
Yes.
Was she eventually stabilized after that code?
She was.
And did they do something as far as intervention to try to maintain her blood pressure?
We increased her pressors. We added 2 more pressors. She was already on 2. They placed chest tubes in.
Huge.
Started what we call a massive blood transfusion protocol.
Unbelievable. Thank you, Nurse Rochelle. Thank you for showing the fuck up, because apparently every physician that is over at South Shore was just willy-nilly like, yeah, let's do a consult. Oh God, she has a spinal injury. Like 0 fucks given. 0 ability to know what was going on or why she may be in the presentation that she is. Guys, sometimes when I think about it, I think like all doctors should be like House. I'm not a doctor. I'm just a nurse. But like House, I loved that show. Loved it. All right. So what? So what? He had a limp and was on Vicodin. Leave the man alone. He was a genius. There was nothing that these physicians went out of their way to say, wait, if A plus B is not equaling C, you need to go back to the drawing board. And the nurses are typically the ones who are like, something's here. Something's here. I'm watching your vitals like a hawk. Are you in shock? What is going on? Why were you still at 82 degrees when you arrived at Brigham and Women's when your documentation lawsuit said you were at 95 degrees when you were still at South Shore? That doesn't make sense. One of these things is not like the other. Significant blood loss, multiple transfusions. Your lab work was out of whack the entire time. You lost a ton of blood at the scene, and your cavities, your lung, your pleural cavity was filled with blood. No one saw it. No one did chest tubes for her at her first hospital.
And did this all occur in the trauma surgical intensive care unit, or did she have to be taken to a different unit?
It all occurred in her room.
And other than medical staff that was treating her that particular night, did you observe anybody else present?
She had 2 police officers outside the room.
Okay, and so did they remain outside the room for the duration?
Always outside the room, yes.
As far as your interaction with the patient on that particular night shift, was she responsive at all during the time that you saw her?
No.
And with intubation, you mentioned she was intubated. Is a patient often sedated in order to maintain intubation?
Yes.
Why is that?
Helps them not fight the vent, and breathe better, and make sure that they're comfortable.
And what does sedation do to an individual?
You're calmer, you're sleeping.
Makes them more relaxed?
Relaxed, yeah.
Yeah.
Other than that first night, the 24th into the 25th, did you have the occasion to treat this patient at other points within that week?
Mm-hmm.
Yes, I have.
And I'm going to draw your attention to January 26th of 2023. Do you recall interacting with her on that day?
Yes.
And is it fair to say that on the 26th, she was still intubated?
She was.
And under sedation?
Yes.
Well, during this time period on the 26th, was she arousable, meaning could you initiate some communication with her?
Some, yes.
And were you able to kind of give her commands in order to care for her that she was able to follow?
Yes.
And when I say able to follow, obviously...
Simple, yeah, commands.
What kinds of?
Like, can you squeeze my hand? Can you wiggle your toes? Just basic neuro check to just make sure she's alert and she's able to understand what you're saying to her.
And for this particular patient, you're aware that she presented with a spinal injury, correct?
Correct.
And so movement of the lower extremities was not something that she did.
Correct.
But did you observe her to move her head around and move her arms around?
Yes.
Now, you also had the occasion to treat her in the overnight shift of January 28th of 2023, correct?
Yes.
And during that time, she was also still intubated?
I believe so. I'm not sure. I've had her both intubated and.
Okay. While she was still intubated, did you have a system that you could use to communicate with her?
Yes, we use the whiteboard. Now I want to go over here. She talks about the restraints. They used soft restraints on Lindsay, meaning it's like this cloth,
how
you would think of it like a cloth handcuff, I suppose, right? That just goes around, but it's not hard. It's not going to go into your skin, but it's going to keep you from pulling at the tubes. This is interesting because we rarely restrain anymore. It's clearly only for safety, but back in the olden days, you'd do 4-point restraints like it was your friggin' job with a lot of psych patients. Now, they had to do this solely to protect her from herself and removal of the tubes. Then we find out she's confused. She writes on the whiteboard, "I can't feel my legs." And she's trying to pull out all the tubes. They do the soft restraints. On January 30th, I want you to hear how Nurse Rochelle describes her.
Her orientation and her alertness.
Yes.
Is that something that you kind of do each and every shift?
Every shift, yeah.
Was she still on sedation medication at that time?
No.
And what was your observations of the patient's demeanor now that she is extubated?
She's flat. No emotions either way.
And is that fairly consistent with what your observations were of her during the course of your time treating her?
Yes.
How about being alert and oriented? Did you observe her to be alert and oriented?
She was.
And did you observe her to?
That's just interesting to me because we're looking at Lindsay, and this is the only time that I've heard, besides psych, is describing the affect. And when we look at Lindsay and we've seen, and I've done like compare and contrast of like photos of her and like seeing her right afterwards, it's like, holy shit. She looks so flat affect, almost, it's like a disassociation almost, like she's looking at you, but through you. And when you see someone like that, a despondence, a detachment, it's chilling. And that's how, with the flat affect, her just saying, "I can't feel my legs." Can you imagine someone saying to you after you've been highly dosed, like sedated like an elephant, and you are like, "I can't feel my legs," and you're like this, "I can't feel my legs." I'd be like, "I can't fucking feel my legs." I'd be animated.
To identify sleep as an ongoing issue.
Yes.
Still can't sleep.
As part of the plan for treating her, did you address the sleep?
Yes.
And how did you guys address sleep?
The plan was to start the first sleeping medication for her. I don't remember exactly which one, and then wait a couple hours, see if it worked, and if not, try another medication.
Okay, and this actually occurred over the course of a few days.
A few days. Yeah.
During the time when you.
Oh, I'm sorry. Did we throw her on some more meds? Did we throw her on more meds? When we know that she wasn't doing well with the meds? Good God. Still can't sleep to save her soul. Can she at this point? We don't know. But holy moly. Multiple medications, still not sleeping. And we know what the toxicology is going to show in a little bit.
Observed her to be flat as far as her affect goes. Did you also observe her to be cooperative?
Yes.
Meaning she followed your directions?
Yes.
She was probably a robot.
Did you treat her, or were you the overnight nurse for her on February 2nd? Do you recall?
Yes.
On this particular night, February 2nd, do you remember her making a particular request of you or ask you for something specific?
I think that was the night she wanted to reach out to her lawyer.
And did you note that in your nursing notes?
Yes.
And why did you note that particular request?
Objection. I see counsel.
Now, while they're talking at sidebar, we know that a couple of days before, when Lindsay was trying to change her healthcare proxy, she had talked to her lawyer. So why is this a big gotcha moment from the Commonwealth?
Thank you. So on this particular night, the second, she made a request of you for her lawyer, correct?
Yes.
Was that something she had asked you before?
No.
And so did you think it was something worth noting?
Yes.
Why would you note something like that?
Because that was the first time she referred to anything going on with the case.
Okay. And so you had the occasion after she was extubated to have some casual conversation with her, correct?
Yes.
Okay. And this was not a conversation you'd had before?
No.
What did you do when she made that request? What was your response?
I sent what we call a consult to the social worker in order to coordinate reaching out to her lawyer.
Okay.
Want to know why? Because she has rights.
In any
Patients have
of the shifts
rights.
that you had been caring for this particular patient, did you see anyone besides medical staff and the law enforcement that were outside of the room come in and speak with her?
No.
Were you aware that she was not to have visitors?
Yes. I was told the first night.
And is that something that you've seen before in your work as a nurse when there are police on site?
Yes.
Were you present at one point when some troopers came in to take photographs of her?
Yes.
And were you in the room when they took the photographs?
Yes.
Do you recall assisting them in viewing the injuries to her wrists and her neck?
I don't know if I don't remember assisting.
Interesting on this. Now, I know that Lindsay is not a minor, right? But I always go back to the Maya Kowalski case and the nurses down at John Hopkins, is that they had to be the ones that helped with the photos for patient privacy. And I just feel like because Lindsay was so compromised, yes, the troopers have the rights, maybe because it wasn't any like sensitive areas. Well, it is, but like your neck and your wrists, bilateral upper extremities are not going to need the assistance, but she is there. She is in the same room to ensure that no funny business goes on. And we know Mass State Troopers leave a little bit to the imagination sometimes for good behavior.
Okay, but you were present.
I was present, like in the room with her.
And fair to say, your contact ended with this patient on February 3rd when she was transferred off of the trauma surgical ICU unit.
Yes.
Correct.
One moment. You were not the only nurse to treat her on the night shift, correct?
Correct.
So on days that you didn't work, another nurse treated her.
Exactly.
And were you familiar with the nurse who was generally assigned to treat her during the day?
Yes.
And who was that?
Megan Collins.
Megan Collins.
Mm-hmm.
And is it fair to say that with the law enforcement presence and this patient's particular situation, the amount of medical staff that were treating her on a regular basis was fairly limited?
Correct.
Meaning it was the same people all the time.
Mm-hmm.
Okay. Thank you.
Attorney Reddington.
Attorney Reddington.
Morning.
First of all, you have the certified copies of
Call them off any objection.
and MRI obviously would be when you're taking the pictures. And that would be on the 24th of January in the early morning hours, correct?
I think it went into the 25th.
Into the 25th?
I think so.
Counsel asked you about the whiteboard that she would write on. And I think it was, again, if I'm wrong, correct me, was it January 28th that she used for the first time the whiteboard to communicate?
Yes.
And the whiteboard basically is just a whiteboard, and you write on it.
Erasable.
And she was not able to speak because
Hey, guess what? The whiteboard is actually just a whiteboard, guys. Okay.
she was intubated, right?
Yes.
And she was in the restraints that you've described as well, right?
Right.
Moving forward, January 28, 29, 30, into February 1st, February 2nd, it was on February 2nd that counsel asked you about her asking to reach out to her lawyer, correct?
Yes.
And do you know who her lawyer was at that time?
No.
Had you seen him before?
No.
Did you know, is his name Attorney Gelb?
No.
Make any reference to you?
No.
Do you know that whether or not she had conversation with Attorney Gelb regarding her status as being under arrest by the numerous police that were guarding the room?
I don't.
Do you know whether or not she was ever able to talk to Attorney Gelb, or did you refer her to the social worker people?
I've put in a consult for the social worker.
Okay, thank you. When she was admitted on the 24th, would you agree that she was in the state of cardiac arrest shortly thereafter?
Shortly after arriving to me.
Yeah.
So I'm looking at the medical records that have been introduced for the jurors, and I'm referencing on page 18, if I may, one page of 400 pages of medical records.
Can you see that?
But looking at this, does it indicate the
Look at this, babes.
ICU course?
Surgical ICU.
I'm sorry?
Surgical ICU.
And that makes reference to the fact that shortly after arriving in the ICU, the patient had a cardiac arrest. Is that there?
Yes,
Were you there then?
I was.
And when it says the etiology of the arrest, she got 2 rounds of CPR before obtaining ROSC. Can you tell me, please, what is CPR? 2 rounds, and what is ROSC?
Meaning we did chest compression. She was already intubated, so she was getting oxygen.
Okay. And then bilateral chest tubes were placed in her body?
This is
Yes.
the
Does
moment.
that mean from both sides?
Both sides.
Okay. And they punctures through the chest into what, the lungs?
The lungs.
And when they placed the chest tubes, at this point, shortly after admission, there was 100 to 300 cc's of blood from each chest tube? What does that mean?
That's the output they got once they put the chest tube. That's the output they got once they put the chest tube in.
Okay. So when they put the chest tube in, it drained 100.
That's a shit ton. Okay, guys, I want you to understand. What is 300 cc's? Okay, sometimes if you're getting antibiotics at the hospital, you can have a 500 cc bag or even a 500 cc bag of normal saline. Think of any time you've had fluids, right? You can have a liter, a full liter. Half of that is 500, 100 to 300 in each lung, both sides. Shut up. Stop it. She was drowning, quite literally drowning in her own blood in a pleural cavity.
300 cc's of blood, is that correct?
Unbelievable.
And then after that, again, shortly after admission to the hospital, coming from South Shore Hospital, she then got a massive transfusion protocol, which you told us about, right?
Yes.
And what does that mean?
Means we have a protocol that with blood, depending blood products,
Okay.
she gets infused rapidly.
And was there a notice shortly after arrival to the ICU, she was being turned and had 30 cc's of clear fluid that came out of her nose? Is that right?
Yes.
And what is that? Was there a suspicion that was what's called CSF?
Yes.
And what is CSF?
It's spinal fluid.
Okay.
Cerebrospinal
Going to the
fluid.
next page, which would be 19. Does it indicate, again, on there, if I can just bring this up a little bit better. So she now has noted acute blood loss, anemia, right? What does that mean?
She has a low blood count.
You know what happened to the blood?
Oh, she was on unison. She had IV
So
antibiotics.
she had very low, lost a lot of blood, right?
Yes.
And she had anemia. That would be what, low blood or something?
Yes.
H and
And
H.
she required multiple transfusions immediately following her arrest, right?
Yes.
And when it says arrest, does that mean arrest by the police or does that mean a cardiac? I want to make sure that's clear. Cardiac arrest, nothing to do with it.
Really good clarification right there from Mr. Reddington to say, when we say arrest in medical notes, is that an arrest from the police or a cardiac arrest? And it was a cardiac arrest that they were referring to. Really good job of making sure that it makes sense to a jury.
And she had required multiple transfusions. And you were there for that, correct?
Yes.
Were you aware of the extent of after you had the after you had the MRIs and the CAT scans, were you aware as the lead nurse or treating nurse as to what the extent of her injuries were?
Yeah.
At that point, I don't believe so.
At some point, did you become aware of that?
Yes.
Okay, so, and again, I've got the records, you don't, so let me do it this way, just to make it easy. Do you remember that she had a burst fracture of C1?
Yes.
What does that mean?
Means a cerebral fracture.
That'll be up here? So this is the cervical spine
Cervical.
here.
Mm-hmm.
And then T5 and T6, there was a transection. What does that mean?
Thoracic.
Okay, so
On the spine.
down here. And when it says transection, what does that mean?
It's severed.
And then T1, 2, 3, 4 also were injured as well, right?
Mm-hmm.
Fractured.
What is neurogenic shock? What does that mean? If you know.
Neurogenic shock. Okay. It's a medical emergency, life threatening. It is characterized by low blood pressure. You have a high pulse. You have warm, dry skin. You have typically in spinal injuries is where we will find that, but it is a shock. It is a life threatening shock. And they documented this in Brigham and Women's.
Neurogenic shock.
Sorry. Yeah. Neurogenic shock. It just makes reference on.
These are not my notes, so I can't really.
That's fine. I understand. And this would be on page 65. Do you recall reviewing the documentation as to what's captioned present illness in the records? Did you know that she was presenting as a transfer from South Shore Hospital?
Yes.
Did you know that under present illness in the history would be that she's a 32-year-old female with history significant for postpartum depression? Did you know that?
Yes.
And did you know that after the fall with the C1 burst fracture and the complex transection of T5 and T6, she also had rib fracture, correct?
Yes.
And then he's going to sneak this little bad Larry in.
On page 66, that would make reference to the time frame going into the 25th, on the 25th, that she was reacting to painful stimuli, right?
Yes.
Yes.
And that basically means that she's not conscious, if you will, but she's able to react to...
If you cause pain.
Yeah. Okay. There's a notation of a contusion, laceration, and crushing of the thyroid with thyroidal edema. What does that mean?
Bad.
She has swelling, I'm assuming, around her thyroid.
Okay. And that is...
Again, this is not my scope
of
practice. So.
Okay. On page 70, the same evening, making reference to the fact that in addition to the injuries to the spine, that she also had the rib fractures and was currently in shock.
There it
Would
is. Not
you
that.
remember that?
That's
she
not
was
the
in
exciting
shock?
part. One more, Mr. Reddington.
Yes, no?
Page 72.
Okay. Would you agree, or do you recall that there's a notation that this patient is critically ill, and noting that she has postpartum psychosis on page 72?
Shut up. This was it. This was it. Ding, ding, ding. Can't put the genie back in the bottle. He said it. He said it. Page 72, Brigham and Women's in the records. It says, quote, I quote, postpartum psychosis. Holy shit.
I see counsel.
When you're treated...
Commonwealth did not like that. Buckingham and her beaux said, fuck all the way off. But we knew. Now the jury is going to go, shit, she did. It wasn't. Oh.
Being a patient, one of the things you try to do is to know what their total body and emotional condition is, what they've been dealing with, and what injuries they have, right?
We get a rundown or history of the patient.
Sure. And as it goes into the end of January, and she had been communicating on the whiteboard, you were aware at that point why she was in the hospital, right?
Yes.
You knew where she came from, South Shore Hospital, right?
Yes.
And you knew that there had been discussion about postpartum psychosis. Isn't that right?
Yes.
Okay. And do you recall that, and this would be on, may I approach you, Honor, the witness?
You may.
Thank you.
You can maybe, if you could show counsel. Wait.
Mr. Reddington's like, no.
I want the date and the time.
Oh, go calm your beaux. Go bunch a beau, Buckingham. Triple B.
So I'm just showing you one page from the medical record. Can you tell me what date is this page from?
125.
January 25.
If I'd ask you if you keep your voice, at least speak of
Oh, sorry. Yeah.
Thank you.
January 25th,
Say what time?
9 a.m., 9:03 a.m.
And looking at that, do you recall on that date, been working with her the night before, correct?
Correct.
Where it indicates that the patient is under arrest, right?
Yes.
Police officers at her bedside. Right?
Outside the room.
Well, it says at her bedside, correct, isn't it?
Not inside,
In the
outside.
record, but I'm saying
The night before,
they were outside her room.
outside. You were not there during the day, apparently, right?
Correct.
Okay. And there's a difference from you guys as far as your medical records. If the police officer is at the bedside as
By
opposed
court.
to sitting in the chair in the hallway outside the room.
Yes.
So indicating police officer at her bedside, we will involve social work and legal teams, right?
Yes.
What are you getting at? He's got a point. He always does.
And again, on page 72, there's a reference to CSF leak, and that's the significant. It says significant amount of fluid coming from her nose.
Correct.
Do you have any memory of observing that in your treatment?
I did.
Okay. And then, of course, there was the code event that you've already described for us. there's 100 to 300 cc's of blood coming from the tubes, and
He's
then it makes
wrapping it
reference
up.
to, on page 74, to massive transfusion protocol. Is that like a medical term, or is that somebody
Yes.
describing it? Or
It's a medical, like it's a protocol that we have at the hospital.
okay. And on page 75, did you make reference to, or did you observe the injuries, for example, to her wrist?
I observed.
Yes. And would you agree with me, page 75 of the medical record, indicating if it says RUE, what does RUE mean? Do you know?
Right upper extremity.
Oh, right upper extremity.
Right upper extremity. 3.5 centimeter deep laceration. Volar aspect of wrist.
We know that. We're going to talk with the other guy about that. I just want to see what else did he say. Left upper extremity and the temperature, and then he made rest to the pressors. She was still intubated. Was the first time she started using that whiteboard. Here it is. Just finishing it
To
up.
coordinate, it's harder at night to, so I wanted to pass it on.
And finally, she was not able to have visitors per order of the police. Is that correct?
Correct.
Correct.
Thank you very much.
Thank you.
Como, redirect.
No, their clarification is nothing. We don't even care. The bucking bows are going to keep going and try to clarify a timeline. Everything that Nurse Rochelle says and that Nurse Megan said, Collins, are great. They really painted the picture. They are not providing the diagnoses, but they're treating the patient. They know what was going on. Yes, Lindsay needed to be restrained. She was under sedation. She comes out of, she still isn't sleeping. She still is uncomfortable. She's utilizing a whiteboard to communicate when she is in soft restraints. Unbelievable. She has ICU delirium. And she also, guys, is suffering from visual hallucinations, which is rare. It is not normal. It is not a typical side effect of coming out of anesthesia or out of being intubated. Like, no, sorry, facts matter, intubation. Now, let me end this. Yeah, bye. I'm going to stop sharing, and we're going to go to our psych provider now. Are we? Find a way. I liked Dr. Shaw. Okay. Give me light.
So my team was
Here we go. Oh, JK. God, I'll do it every time, guys. Present, share it. Are we doing that? Yes, we are, because we can figure out technology. Boom.
for a number of reasons, including for psychiatric.
Okay, Dr. Shaw. She is incredibly educated. She is the, let me get what she is. Associate director of inpatient and outpatient. She's like the liaison of psychiatry for Brigham and Women's. She has been trained forever. She worked at Beth Israel Deaconess Medical Center too as a consult. Then she went over to Brigham and Women full-time as staff. Listen to what she says. She's pretty interesting.
Safety risk assessment. She had come in reporting a suicide attempt, which is a common reason why.
No, but that's not actually accurate, Doc. I love you, but we're going to correct the record. She didn't come in reporting anything because she was intubated, but it was a reported attempt.
My team would be called is to continue to ensure that patients are safe when they're in the hospital. So we make recommendations about kind of safety status, what can we do to help keep a patient safe? But then we also make recommendations related to medications. So that's why my team was following her. So that was one of the reasons why I saw her on the 29th, is to continue that assessment. I was also called to ask I was asked a new question that day, a consult question on whether she was able to make the decision to change her healthcare proxy from her, at the time, husband to her parents.
And when you consult to help determine whether someone's capable of making a decision like that, changing their healthcare proxy, are you evaluating their medical decision-making capacity?
That's correct.
Okay. How do you go about doing that?
So there's generally 4 parts to medical decision-making capacity. The first is whether somebody's able to voice a choice and whether that choice is consistent over time. The second is whether they understand the situation under which they're making that choice. The third part is appreciation of the risks and benefits. And the fourth part is kind of being able to reason or rationalize that information to be able to come to a choice and how they came to that choice.
Now, if you're doing this evaluation to determine someone's capacity to make decisions. Would a traumatic brain injury factor into that evaluation?
It could. Traumatic brain injury.
When you evaluated Lindsay Clancy, was she able to voice a choice to you about who she wanted to be her healthcare proxy?
Yes.
And is she speaking to you or writing this down?
She's speaking.
So she's already been extubated at that point.
That's correct.
And she's speaking to you. And were you aware that Patrick Clancy was her healthcare proxy?
I was told that by her primary medical team.
Okay. And when you talked to Ms. Clancy, did she tell you who she wanted to take over that role?
She did.
And who was that?
Both her parents.
And you talked about that needing to be a consistent choice. How did you ensure that was a consistent choice with her?
Yeah, so we waited to make the change from Patrick Clancy to her parents until the next day for a variety of reasons. We wanted to ensure that choice was consistent over time, and especially because the day that I saw her, she had just gone through some pretty major medical events, including she had a major spine surgery, a decompression and a fusion. She had gone through some oxygen desaturations overnight, so was not breathing as well. Her heart rate was up, all of which then led to her being what we call delirious. She was confused overnight to the point where she asked her nurse, "Am I delirious?"
Why Lindsay is also asking, "Am I delirious?" is because she's a friggin' nurse. She knows. And she's like, "Oh, it's happening. Oh shit, it's happening."
And she was also experiencing some visual hallucinations.
Boop, 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 boop. That's weird. That's red flaggy.
So that was one of the reasons why I was called in, to make sure that she was able to make that decision to change her healthcare proxy. And then in addition, the team had also voiced, concerns that she had come in after a reported suicide attempt. And so making sure that she was able to make that decision of sound mind. And so we actually waited until the next day when she could be reassessed. At that point, her delirium had cleared, and she was continuing to make that consistent choice to change her healthcare proxy to her parents.
And in fact, you noted in the medical records that the hallucinations were part of an issue with oxygen.
It could be. That could be one of the reasons. Delirium is usually due to a variety of different medical reasons, and oxygen desaturation could be one of them. She had also just recently had anesthesia related to surgery that she had on her spine, so that could be another reason. And then her heart rate was also actually quite elevated, so that could be another reason.
Is it common for patients who are just coming off of anesthesia from surgery, who have an issue with oxygen and other medical issues that you described, to have visual hallucinations?
They can.
Yeah, but she didn't say it's common. They can. Yes, they can. But any nurse in the chat, think about that. We absolutely have seen people have a change in mental status. But visual hallucinations is another animal completely. And to me, that is indicative of underlying condition. It can be, but that's not a typical side effect for the visual hallucinations.
It's not that everybody does, but they can, and delirium can be quite common after surgery, and particularly anesthesia.
And those hallucinations that she was having, those were resolved by the next day. They were over by the next day, correct?
That's correct.
And her choice to change her healthcare proxy to her parents was consistent the following day, correct?
That's right.
You also talked about the patient has to understand the risks and benefits of the decision, correct?
That's correct.
How do you make sure the patient understands that?
Yeah, so one of the things we do is really ask patients to take us through their thought process of why they're making that decision and what led to them making that decision at that moment in time. So we're able to kind of see their thought process and ensure that they're understanding, what it means to remove one person and add another.
And what was Ms. Clancy's thought process in explaining that to you?
Yeah, she was saying that her parents were quite supportive to her and that she was.
Very interesting. Lacey Ann says, I've seen visual hallucinations maybe 10 times in 15 years. Do you work in an ICU, babe? Because in psych, I have seen it more frequently, but in an acute setting, absolutely not. I think I maybe seen it once.
Thinking that she would have to change her healthcare proxy from her husband to somebody else. And we didn't necessarily go into the reasons as to, why she would have to change it, but she explained that she was very close with her parents. They would see each other frequently, given that they lived in close geographic proximity.
This is another time where you can't put the genie back in the bottle. And if this jury is paying attention, I want you to watch Dr. Shah's response to a question that's asked right now by Buckingham.
And that she felt that they were very supportive to her and would have her best interests in mind should we need to invoke the healthcare proxy, or that if she couldn't make her own medical decisions.
So was there a concern on her part that her husband wouldn't have her best interests in mind at that point in time?
Well, she answered it. Was there concern that her husband wouldn't have her best interest in mind at that point in time? Big shake head no. Because that wasn't the point. I don't get why this is such a big aha moment, or why the Commonwealth is spending so much time. You wanted to change your healthcare proxy. Maybe Patrick wouldn't be like, hey, want to be a DNR? Cool. No. Oh, maybe my husband is suffering, like quite literally suffering the worst loss that he could possibly. Maybe I could ask my mom and dad to do it.
Sustain.
You also talked about the patient. You have to make sure the patient's thinking about the information rationally. How do you go about doing that?
Yeah, so one of the things we do is really ensure that the patient understands the situation and all of the kind of parts around it. So this comes into play much more when it's about a specific medical intervention, like an invasive medical procedure, or something like an amputation or a surgery. With a healthcare proxy, one of the things you want to make sure is that the person that they want to change their healthcare proxy to or appoint as their healthcare proxy makes sense in the context of their life. And Ms. Clancy was able to talk about how her parents were quite involved in her life, and so that's one of the things that we would assess.
Okay. And then the last thing was making sure the patient understands the risk if the change doesn't happen. Did you go over that with Ms. Clancy, and how did you do that?
Yeah, I did go over that with her. We talked a little bit about how it could mean that she would not have a healthcare proxy were she not to appoint her parents, and so we went through that.
It's the risk and benefits, and we're always going to do that as providers, and your team will do that with you. Now, in the event that she did want to go to a DNR and a healthcare proxy was invoked because she didn't have capacity to make her own decisions, which Lindsay did have capacity to make her own decisions. So this was not affecting anything. She would have still remained a full code if she was without. If you are without a healthcare proxy when it is active, when one needs to be activated, you will always default to full code.
It's always in healthcare, we always talk about how it's great to have a healthcare proxy just in case you become unable to make medical decisions. And who would you want that to?
Now watch this. We want to talk about a brain injury.
Bedside cognitive evaluation, and she definitely made some mistakes on some of the cognitive evaluation. Therefore, I did diagnose her at that time with delirium.
And then she was reevaluated the following day, and there were no issues with her understanding, and the delirium was gone, correct?
That's correct.
And were you aware during this evaluation that Ms. Clancy did not have a brain injury?
I'm sorry, can you repeat the question?
Were you aware that Ms. Clancy did not have a brain injury at that time?
One of the things that we look at is any kind of relevant medical information that might be available to us. And I noticed that her Glasgow Coma Scale, when she was transferred to Brigham and Women's Hospital, was a 10.
Okay, so that's your level of consciousness. Your Glasgow Coma Scale is like how alert you are. She was a 10. That is severe. No, is it? Let me make sure. I know that it is. No, I lied. It's moderate. And what it is basically telling us is like, hi, that doesn't mean that you don't have a TBI or traumatic brain injury. This means that she is impaired, quite literally impaired. Coma was at one point not alert and oriented. Although allegedly she opened her eyes, per Dr. Kelly, everything else is giving brain injury.
Which would indicate that she could potentially have had a moderate brain injury. But I don't recall thinking about whether, specifically whether she had a brain injury.
Because if you have a brain injury, you can still be what? Competent.
Were you aware that a CAT scan was done, page 110 of the records? And
watch this. Let's knock him out of the park, Dr. Shaw.
on the CAT scan, the impression was no acute intracranial findings. So no brain injury.
So you can, I did review the head imaging that was available at the time. You can have a normal CAT scan and still have a brain injury.
Yeah. So remember when you put that on and you were like, yeah, she didn't have any bleeding. Yeah, she didn't have a stroke. Okay, great. Thank you. But that doesn't mean she doesn't have a brain injury. Thank you so much for playing. Glad you're playing a physician on TV with bows. Here's a real one. No bows. Get a bobby pin.
Were you aware that she had multiple CAT scans that showed no bleeding in the brain, no skull fractures, No injuries, just visible injuries whatsoever.
I'm sorry, but can you repeat the question?
Were you aware that she had multiple CAT scans at South Shore Hospital and at Brigham and Women's that showed no skull fractures, no intracranial bleeding, no hemorrhaging, no visible damage whatsoever?
Yes.
Okay. And were you aware that she was evaluated at South Shore Hospital and at the Brigham, and she had no external injuries on her head either?
Yes.
Now, she was allowed to change her healthcare proxy to her parents, correct?
That's correct.
So if someone had an injury, a brain injury to the point where they didn't know what was going on, or they were having trouble processing or thinking, they wouldn't be allowed to change their healthcare proxy, correct?
It depends to what extent. Most patients that have either a head injury or severe mental illness, let's say, just anything going on with the brain, retain the ability to make most medical decisions. And we think about changing healthcare proxies as a pretty low risk decision. As I mentioned before, something like an amputation or a major surgery, invasive procedure is something that we would hold somebody to a higher bar. But a healthcare proxy is a pretty low risk, especially if it makes sense in terms of who they want to change it to.
And when was her Glasgow score a 10?
I believe it was as she was being transferred from the outside hospital to Brigham and Women's.
And you're seeing her several days later, correct?
Correct.
And so when she was transferred from the outside hospital to Brigham, she was unconscious, correct?
I believe so.
Okay. So now she's conscious, correct?
That's correct.
And when she was transferred from the outside hospital to Brigham, she wasn't communicating or speaking or opening her eyes on her own, correct?
But that's what the reports said. I was not there at that time, but the notes that I read, that's correct.
So when you're speaking to her a couple days later, she's opening her eyes, she's communicating, she's responsive, she's interacting, correct?
Yes.
So it's fair to say that her Glasgow score would be higher than the 10 when you were speaking to her, correct?
Yes.
Now, you did a mental status.
All right. We don't really, what was the intent? What do we do here? Looking forward to moving her to Spalding. All right. Now let's get to Mr. Reddington.
Slurring her words or anything like that when she was able to talk.
Right.
Okay. One of the things that when she was admitted, and then without going through, I'm not going to go through all the stuff we've already talked about with the medical condition and everything else. You indicated that she was very, very ill, correct?
Correct.
Did she appear to be cooperative to you when you would interact with her?
Yes.
As a doctor, as a psychiatrist, you're familiar with bipolar, the concept of a bipolar diagnosis, correct?
Correct.
Can you tell me what bipolar means?
Yeah, so bipolar disorder is a mood disorder, categorized as a mood disorder, where patients have distinct depressive episodes, as well as, depending on the type of bipolar disorder, either hypomanic episodes or manic episodes, to the point where they don't sleep for days. They still have lots of energy. There's this decreased need for sleep. There could be irritability. There could be impulsiveness, racing thoughts. A lot of patients describe that they're out of control of their behavior. And then severe episodes can also include psychosis.
And in reference to bipolar, as you were referring to, when somebody is hypomanic, what does hypomanic mean?
Yeah, it's a lesser degree of mania. So when patients are hypomanic, they don't always experience things like psychosis, but they might experience some of the other symptoms that I described, including racing thoughts, kind of moving too quickly, talking too quickly, being irritable.
And as it relates to the hypomania, would that include things such as somebody who is getting up early in the morning and exercising, or cleaning out their house, or selling their property out of a garage and having difficulty sleeping, and they're awake all night?
Yes.
As a psychiatrist, one of the things you were concerned about when you were first started to deal with her, as well as when you were releasing her, if you will, is the medication that she had on board, so to speak, when she came into the hospital, right?
Yes.
Do you remember, and I know it's difficult to recall offhand, but do you recall the medications that she was actually under from purposes of taking her blood when it was tested?
When she first came to the hospital?
Yeah, if you know.
I believe her medication list for, previous to the incident, she was on amitriptyline, diazepam. I believe she was also on prescribed lorazepam, and there may have been one other.
Yep. Clutch your buttholes, everyone. The other one was the antipsychotic quetiapine, also known as Seroquel. Can I say quetiapine? No. So I'm going to say the trade name. Stop it. And these were all prescribed in rapid succession over a few months. Take it in. Take it in.
Okay. So looking at that, if I tell you that there was a toxicology report done on her as of January 24th by way of taking her blood, you're familiar with that, right? When they analyze for toxicology. And toxicology obviously would tell us what the medications, if any, what type of drug she had.
Right, Lauren. Oh, sorry, babe. Lauren, I totally hear you. The Commonwealth is going to use it if she was of sound mind to make this decision to change her healthcare proxy, was what she's talking about. Then she was therefore of sound mind when she unalived her children. Except we know, because we're nurses, Lauren, that psychosis doesn't take you. It can come and go in minutes. Do you know what I mean? And like that, you having the capacity to make that decision on the 30th of January after the tragic events of the 24th, like, no, you can't equate that. And I think, in my humble opinion, that Reddington will be able to say, you know, this didn't even happen, in my opinion, like that same afternoon. She's still, Lindsay, at the very day of this tragic infamy, all right, this will go down forever, is that she was still planning by asking, in my opinion, having Patrick go to CVS for the Pedialax. That's you still trying to hold on and still trying to be like, I need to make sure that Cora can move her bowels. Like, I don't see that even in the time that he had left, whether it was before or after the call, will make a difference. That she heard the command to hallucination, but like it can be very quick and resolve very quickly. And then you are left with the aftermath, and an aftermath that should have never happened because you sought help for months in every human motherly way possible. Whether it's inpatient, outpatient, partial patient programs, McLean Hospital, voluntary psych admissions, what the fuck else was she supposed to do? She did it all, in my opinion.
Had on board booze, cocaine, anything, right?
Yes.
And you're aware that the toxicology report, as well as the report from the Department of State Police, as well as the NMS laboratory, which would be in Pennsylvania. So that's an international or a national respected laboratory, isn't it? The NMS lab, if you know?
I don't know.
Okay. But you know that they did take her blood, they did test her blood, and it was at the state police laboratory as well as any other labs that tested it, right?
Yes, I believe I found that out later. I did not know that the first time I saw her because those labs take a little bit of time to come back.
And you treated her for about a month, so you were pretty
That's
close to her and got to know her quite well?
Yes.
Would you agree with me that one of the things that her blood reflected or that she was on was trazodone?
Yes.
And can you tell me what trazodone is?
Yeah, trazodone is an antidepressant medication.
Atypical,
It's
used for sleep.
more often utilized as a sleep aid because of one of the side effects is sedation. And so patients that are often having difficulty sleeping are placed on.
And is trazodone, does that share some of the qualities of what are referred to as SSRIs, even though it's not an SSRI, it shares similar qualities?
Yes.
Can you tell me what SSRI means?
Yeah, so that's a selective serotonin reuptake inhibitor, and it's a class of medications that are antidepressants.
And the SSRIs, that would also include Zoloft, for example?
Correct.
Would also include Prozac, for example?
Yes.
Are you as a psychiatrist aware that Zoloft and or SSRI Prozac should not be prescribed to a patient who has bipolar?
It can be prescribed. Oftentimes it's prescribed together with another medication that can be protective because patients with bipolar disorder may be experiencing depression. And so they may be prescribed an antidepressant, but along with another medication that...
It's not okay. So she's being very politically correct, and we love that because she is a queen and she is playing to her education and her training and experience. But what she's saying is like your Abilify. You have to put something else that is going to stabilize your mood, babes. Because if not, what you do is that SSRI can make a bipolar individual into a major depressive disorder, aka or suicidal ideation, homicidal ideation, bad outcome. Bad outcome.
What we call protective.
And in reference to the SSRIs, the selective serotonin reuptake inhibitor, what does that mean? Selective serotonin reuptake inhibitor. What does that mean?
Yeah, so oftentimes in depression, patients are kind of lacking serotonin in the spaces in their brain.
Bitch, I've been lacking serotonin since 2010.
That helps.
Can I interrupt you? What is serotonin?
Yeah, serotonin is a neurotransmitter.
Dopamine.
It's a hormone in the brain that works on the brain. It works in other areas in the body as well, but for these purposes, it works in the brain, at nerve endings, throughout the body. And that neurotransmitter helps with things like mood regulation. For patients with depression, they're often lacking kind of that ability to have enough serotonin in those spaces. And so a selective serotonin reuptake inhibitor prevents serotonin being kind of sucked back into the cell. So
you're not burning through it. And Veronique 4465, stop it. Thank you. You had a shitty day. Thank you for sending me some love from California. I'm sending you some love from Massachusetts. Thanks for hanging out with me.
Allows for serotonin to be more available.
And what is an SSAI? What does that mean? Antagonist, selective serotonin antagonist.
So those are medications that kind of do the opposite.
Okay. And you knew, as a psychiatrist, at least looking at her history, you knew that she had been seeing psychiatrists immediately prior to her suicide attempt, correct?
Correct.
And you knew that she had been prescribed a number of drugs by these various psychiatrists, correct?
Correct.
And to your knowledge, was she prescribed diazepam?
Yes.
Valium? Was she prescribed buspirone, otherwise known as Vanspar?
Yes.
How about Wellbutrin?
Yes.
And what is Wellbutrin? Is that an antidepressant?
It is an antidepressant.
Hydroxyzine. What is hydroxyzine?
It can be used for a number of reasons, but for psychiatric purposes, it's often used as an anti-anxiety medication.
And Klonopin.
Yes.
Is hydroxyzine, is that a...
Why are we on diazepam and Klonopin? What? Why?
Strike that. Klonopin, that's a benzodiazepam, right?
That's correct.
And then lamotrigine.
Lamotrigine?
Yep, lamotrigine.
Lamotrigine, sorry.
Yes.
What type of medication is that? Is that a mood stabilizer?
It is, yeah. It's also an anti-seizure medication, but in the psychiatric realm, it's used as a mood stabilizer.
And then we talked about Prozac. That's an SSRI, correct?
Correct.
And what's Remeron?
Also an antidepressant.
Off-label.
So in addition...
Off-label, we use it for the elderly for weight gain and also for sleep. But it can make you have increased adverse effects.
To all of the drugs that I had mentioned, she was also prescribed Remeron, correct?
Correct.
She was also prescribed Seroquel or quetiapine.
Yeah, quetiapine, yes.
Quetiapine, okay. And what is Seroquel?
So Seroquel is an antipsychotic.
Okay, so, and I want to say that louder for the people in the back. When you think about a postpartum psychosis by nature is a psychotic episode. You had her on an antipsychotic. You had her on enough Seroquel that would take down a 500-pound man. She could have been Tammy from My 600-Pound Life, and she would have slept for a week and a half. She didn't. On 300 milligrams of Seroquel, not increased over time. Yes, there are plenty of patients that could be on 600 milligrams, be at twice a day, right? Who the hell am I? But that is over an extended period of time. This was in 2 months. She was increased from 0 Seroquel to 300 milligrams. Fuck off. Negligence.
Medication.
And she was prescribed, as we already talked, trazodone, Was she also prescribed amitriptyline?
Yes.
What is amitriptyline?
Amitriptyline is one of the older antidepressants. It's a tricyclic antidepressant that can often be used to help with sleep, but also mood.
Yeah, she's never slept a day in her life.
Correct?
Correct.
And zolpidem.
Yep, Zolpidem is the generic.
That is Ambien. And Ambien? Guys, there was a class action lawsuit for everyone who was ordering on fucking Amazon and going out and driving like their vehicles at 3 a.m. and didn't even remember. Do you remember that? Do you remember when all the doctors stopped prescribing Ambien because you were having like out of body lucid fucking weirdo events? And you were like, oh, I spent my entire savings and it was delivered to my house. And then I went to go pick up pizza at 3 a.m.
Name of Ambien.
Safety.
Oh, okay. Some of these drugs, they also have what's called a suicide warning or a black box warning. Isn't that right?
Yes.
Can you tell me what that means?
Yeah. So in studies that have been done, some of them show that especially after starting an antidepressant, it can increase someone's risk of suicidality. Many of those studies showed that it was mostly in adolescents and young adults, but it can happen in adults as well.
And
I call bullshit. I understand. And I don't mean that because I know her and I know that she's a love, and I'm sorry, I didn't mean to do you dirty. But here's the thing. When they say that the black box warning is for the young adults, I don't care. It can happen to anybody, and every human is individual. Like medications and psych medications are 100% on a case-to-case basis. There is no one size fits all. You understand that. But we do know, and we are like capable as a medical community to say, well, this should not be used with this diagnosis. But the fact that you have multiple black box warnings on meds that you keep giving, and I mean, these are meds that this woman could not sleep. A bipolar diagnosis should have been at the forefront of anyone's mind, like it was Dr. Shah's. But it wasn't. And she wasn't treated. And then the worst outcome happened.
Alexa was also a drug. Is that an SSRI too?
It is.
And all of these drugs that we just went through were all prescribed from end of September till January.
Yes, September 2022.
4 month period.
Yes.
It's an awful lot of drugs to be prescribed in 4 months, isn't it?
Sustained.
Thank you.
Thank you.
Almost redirect.
Yes. Doctor, all those drugs that defense counsel just listed, you're aware she wasn't on all of those drugs at the same time, correct?
Correct.
But she was prescribed them all in a 4-month period. Get the fuck all the way out of town. You know, sit and spin, bitch. No offense. Gently. I'm sorry. That's rude. I don't mean it. But it's irresponsible for providers to even attempt to add and change meds when we know damn right well it takes 6 to 8 weeks for you to have any sort of therapeutic range. So how in 4 fucking months, which would be 2 actual cycles if we're being serious, most doctors would say it takes 12 weeks for it to really be in your system, and she had that many meds that were prescribed to her. Stop it.
And did you know that many of those drugs she took a very small amount of? Some she didn't take any pills at all.
Oh.
I was not aware of that.
For BOMBSHELL, which is one of the ones he mentioned, were you aware the first prescription she only took 2 pills out of that bottle?
I was not aware.
Were you aware the second prescription a month or so later for BOMBSHELL she took 0 pills out of that bottle?
I was
not
aware.
Good, because that would have made her
so
more
you're
crazy.
Where are you getting this information about what she was on and when?
Yeah, so one of the things that we do is try to collect as much information as we can during our assessments. And so we look through the record in terms of what was prescribed. We also talk with other providers as to what they prescribe.
What I'm getting it from is my math pat. I'm getting it from Remedium that is going to tell me exactly what was prescribed to the patient. That's actually where we're going to get it from, because we're Massachusetts and we're mandated to have some sort of synced list of medications that has been prescribed. It should be a national platform. Thank you.
But in the context of the assessments that we were doing, it did not require us to determine, what exactly she had been on before, because we were using a different set of medications to treat different symptoms that she was experiencing.
Okay. So you really have no idea what she was taking or when. You just know what was prescribed.
I know what was prescribed, and then we were also getting reports of what was being taken, what wasn't being taken. But
from the defendant?
Correct.
Okay. So she's reporting to you that she took those medications, but you'd be surprised to know that at least one of them, 0 pills were taken.
Okay, and this is the least benign one. The Boost Bar, who gives one fuck about, okay? No offense. Also, I took Boost Bar one time, and it was like for smoking cessation in the year of our Lord, I think 2008. And I quite literally thought I was Fred Flintstoning and like driving to work with my feet. I was fucked. Had to get right off of it. Okay. I took it for like 4 days. Very sensitive, highly sensitive to the meds. So there's that. Now they're trying to make Dr. Shah feel like, oh my God, she didn't even know. Bitch, now we're going in. This is going to be our last one because we can't be here for 10 hours. But you know who the hell we're going to do now? Oh, you know it. We're going toxicology today because you're a lying sack of shit, Commonwealth of Massachusetts.
I don't think I'm surprised.
No, you're
No.
not surprised because you're a queen.
And you talked about prescription and what she was taking. Were you aware that in the time frame just prior to her being admitted to the hospital, she was only prescribed trazodone, Valium, and amitriptyline, just 3 medications?
Yes, I was aware.
And you were asked about, mania and.
Okay, do you hear her? Do you hear that she says it was 3 medications she was prescribed? Oh, really? Really? Is that accurate? Okay, because our toxicologist is going to say that she had 800 nanograms. Was it? 800 nanograms per milliliter of Seroquel coursing through her veins.
And, exercising and cleaning out your garage and selling your belongings could be signs of mania, correct?
Correct.
But there are people who just exercise every day and they're not manic, correct?
Of course.
And there are people who have a messy garage and have accumulated a lot of junk and decide to clean out the garage that aren't manic, correct?
Yep. Okay, so now she's a hoarder. God bless you, Dr. Shah.
And in fact, if someone is manic and attempts to do one of those tasks like cleaning out a garage, it's usually in a disorganized way, and oftentimes they don't finish the task, correct?
Sometimes.
So if someone approaches a task like cleaning out the garage.
Well, we have ADHD, okay? So we don't finish many tasks.
Garage, by organizing with another party, organizing the belongings, separating them into keep, sell, throw out, that's pretty organized behavior, correct?
Correct.
And if someone sells belongings that they no longer need, that's not necessarily a sign of mania, correct?
Correct. Okay, now hold. We're going to stop sharing. And it's going to be this one because I'm about to knock your fucking socks off. You're going to say, Kim, stop it. I'm going to say, no, I can't. Hashtag can't stop, won't stop. Dunday. Where did I put him? No. Find your home.
So I wanted to pass it on.
Where did I put my downloads? I hope that this one's going to work because this guy was kind of idiotic. Dr. Justin Brower. Calm down. Mother shit. It's not a loud one. I'm sorry, guys. I have to download another thing. Dr. Brower. Testimony. And then I'm going to read you things. You're going to be like, stop it. Stop it, Kim. Is this louder? Hello, friend. Thank you, channel that I'm going to use, maybe. Megan, I appreciate you.
Justin Brower, B-R-O-W-E-R. And what do you do for work, sir? I'm a forensic toxicologist for NMS Laboratory.
And where's that laboratory located?
The laboratory is located in Horsham, Pennsylvania, just north of Philadelphia.
Concerning, never trust a man with a list.
We are a reference laboratory. We do postmortem work, clinical work, and forensic drug work. So primarily my role is on the forensic side. I'm a forensic toxicologist.
And does your lab receive specimens from all across the country?
We do. We have clients in all 50 states. We do approximately half of the postmortem work in the United States, as well as a large number of clinical clients.
And is your lab accredited across several states and across the country?
We are, because we deal with all the states in the United States, all the states in the country. We are accredited by just about every accrediting body that I'm aware of in the clinical and forensic aspects, as well as a lot of state certifications. So a lot of states have their own requirements. The most notable one is like New York State. So we're accredited by.
Diane, noted. I'm sorry. I get excited. I'm going to be professional. She's a professional queen.
Again, every accrediting body that I'm aware of.
And how long have you worked for
I appreciate
NMS
you. Bear with
Laboratories?
me.
4 years as of August 1st.
What's your educational background as a forensic toxicologist?
I have a PhD in organic chemistry.
Where did you get that from?
Okay, so he knows all of his stuff, right? Now watch. Now watch this. She's going to be like, oh, let me show you.
And for the first, can you tell us what the result was?
Would you like me just to run down the list?
Sure.
We detected lamotrigine in a concentration of 6.1 micrograms per milliliter, mirtazapine at a concentration of 200 nanograms per milliliter, quetiapine at a concentration of 1,800 nanograms per milliliter, and trazodone at a concentration of 0.44 micrograms per milliliter, and these were all in blood.
In blood. And so with each drug that you just listed, are you familiar with what the common name is for the drugs?
I'm not always that great with common names, but I can.
Oh, he's a forensic lithologist, and yet he doesn't know the common names for the drugs. I might not be able to say a generic name, but I absolutely know what it is. I want you to take a moment, think in your brain, say, hey, Kim, oh, what was it? What was that Seroquel level? And I thought it was 800. Oh, well, riddle me this. Okay. We're going to pull it up. Toxicology in blue. Oh, wait, no, those are just the tubes. Okay, we know that. Expected range for a Seroquel being an antipsychotic medication, high incidence of adverse effects on patients at times. Okay. You see that the expected lab reference range is 100 to 1,000, but the AGNP consensus guidelines specify a narrower optimal target range of 100 to 500. Toxicity threshold is reached when levels exceed 1,000 nanograms per milliliter and are generally flagged as toxic and increase the risk of severe side effects. Facts matter. Medical journalism. Okay, Lisbon ain't easy out of Philly. What are we doing? What are we doing? She was at 1,800. She was at 1,800. That is a unbelievably untherapeutic. Supra, that's what we say. All right. So you're either sub, under therapeutic, or supra therapeutic, over. Also, sidebar, none of these meds, unless you have to do a tox for like, I guess your benzos, maybe if you're doing a tox screen that your doctor wants to make sure you're not either overtaking them or you're using them appropriately and not like selling your medication on the black market. The only medications that psych-wise that I can really think off the top of my dome that you're doing a therapeutic level for is like a lithium. And a lithium level, because if you're super therapeutic or subtherapeutic, you can be in a really bad spot. But this isn't something, Seroquel is not something that is typically quantified by a toxicity range. It is quantified by patients reporting symptoms. That's why we change meds. Is this helping? Is it not helping? Your body, your chemistry is different than mine, babe. So what will be helpful to some would not be helpful to others. And that is where this man getting on a stand and saying that a Seroquel level of 1,800 nanograms per milliliter, it's textbook toxic, over therapeutic, too high level. And we'll find out afterwards that her benzos were subtherapeutic. She was just right under the level. So if nothing is in a range that's typically could be working for you and your symptoms aren't improving, then why are you on these meds? Hello? Hello? Anybody? Don't know. Couldn't tell you. I don't like Sir Lisps a lot.
Wing it.
Okay. Well, the lamotrigine, and forgive me if I botched
That's okay.
the pronunciation. That's also referred to commonly as Lamictal.
It is correct, Lamictal.
What kind of drug is that?
It's typically used as an anti-seizure medication. So if somebody has a seizure disorder, it can be prescribed to alleviate seizures, but it is also used for bipolar disorder as well.
And mirtazapine, fair to say that's commonly referred to as Remeron.
Correct.
And what kind of drug is that?
That isn't typically an antidepressant.
And quetiapine, what's that common drug?
Quetiapine is known as Seroquel.
And fair to say that's an antipsychotic as well for bipolar?
Yes, ma'am.
Are you familiar with whether that often can be prescribed in low doses for sleep?
It can be for insomnia.
And trazodone.
Off-label.
What's the common name for trazodone, if you know?
I am drawing a blank on the trazodone.
If I suggest trazamine, is that familiar?
Not the one I'm most familiar with, and I apologize.
That's okay, but you're familiar with trazodone?
Correct,
And
yeah.
what class of drug is that?
That's an antidepressant.
Now, in your review of the levels that were detected in these 4 tests for each of these substances, do any of these levels appear to be outside therapy?
Deborah, are you telling me that he succeeded in beating depression? Or a terrible outcome? I'm sorry, or I'm very happy.
Therapeutic concentration levels.
The only one that's a little elevated would be the quetiapine.
Okay.
We're gonna take a very short break at this time. All right. So this will be a short break, and we'll come right back.
Short break.
Achieve when they're taking the medication or drug as indicated by their prescriber.
And are you familiar with toxic concentrations or suicidal concentrations?
I am.
And what does that mean?
Those are
Okay, something's not called, oh God, that's so ignorant. Nothing is called a suicidal concentration. Nothing is. It's just toxic.
concentrations that could lead to adverse events and potentially death.
Now, in relation to the 4 substances that were tested at the NMS laboratory, you identified the levels for each of the 4 substances. Were any of those concentration levels considered within therapeutic concentration?
It would all be in what I would say therapeutic concentration, except maybe the quetiapine, which is slightly elevated.
Okay. And in your experience as a forensic toxicologist, have you had the occasion to review cases, post-mortem cases in which suicide was a mechanism of death where the person consumed medication?
Absolutely, yes.
And so that level of the quetiapine at the 800 nanograms per milliliter.
It was 1800. And also sidebar, that it would be if somebody took all their pills as a mode of self-checkout. We know that Lindsay did not take all of her medications, and she did multiple other steps as a form and the mode of self-checkout. What are you talking about, Guy?
Would that have been in that toxic or suicidal level?
No, ma'am.
Would you generally expect to see that significantly greater in a suicide case?
Typically, quetiapines in suicide cases might be in the, close to 10,000 nanograms per milliliter. Usually people take handfuls of pills when they're trying to harm.
Well, right. That would be if they were trying to do that with pills. Thank you. Thank you.
Themselves and take their own life. And this is not consistent with that.
Now,
so
are you also
ignorant.
familiar in your training and experience with the class of drugs called benzodiazepines?
Yes, ma'am.
And do you have the occasion to interpret data as it pertains to concentration levels for those?
Every single day.
And as far as the substances diazepam, noradiazepam, oxazepam, temazepam, lorazepam, you're familiar?
Right, babe, but it wouldn't be like that. He's making it seem like that was the mode, right? I think that if you have taken some medications, and I believe Lindsay took her benzos versus her Seroquel, but correct me if I'm wrong. And I don't want to be graphic here, but Sometimes people would like take all of their medication and like maybe down it with alcohol and then just try to go to sleep and not wake up.
Familiar with those?
I am.
And
She picked a very
it's fair to
different
say
path.
noradiazepam, oxazepam, temazepam, those are all metabolites of diazepam.
Typically, yes, ma'am.
And what's the common name for diazepam?
Valium.
If I show you what's marked as Exhibit 183 already. Can you see that on the screen beside you?
I can, yes.
Okay.
Okay, so babes, when you're looking at this, you're going to see that there is toxicology of blood. We have a purple top, we have a blue top, we have a light blue top, and those are just the different tubes that the blood was collected in. And it's going to give you all the levels, and he's going to say that only one of them was a subtherapeutic, meaning slightly under what a regular normal range would be. Again, though, these drugs are not typically managed via like blood levels, only like lithium would be, right? Or Coumadin for people on blood thinners. So like it is often based on signs and symptoms reported from patients to physicians, and adjustments are made accordingly. This being done, all of these meds and all of these med changes in 4 months is atypical. It is incredibly rare. We also learned today that Lindsay has in her Brigham and Women's, like in her chart, postpartum psychosis, page 72. Look it up. That's huge. Because we know that that's a life-threatening emergency. And I feel as though the medical testimony of the providers from South Shore Hospital going over to Brigham and Women's, hearing our psych provider, and then Sir Lisps a lot, just wrapping it up for us for the rest of the day, because I've already been here for 2.5 hours, and you're like, Kim, shut up. Like, something in the milk ain't clean. And there were all the telltale signs of bad, very bad outcomes occurring, and lack of sleep alone in conjunction with a postpartum depression that morphed into short-term postpartum psychosis and resulted in the loss of life of 3 beautiful children and a factual attempt to take Lindsay's own life. I no longer will subscribe to anyone who says, oh, well, she was just hanging, she was dangling, she was a dangle-doogle. No, not with a transection of your spinal cord. No, lies. Not with 100 to 300 mLs of blood in your pleural cavity. Chest tubes, bilateral. Not with your broken ribs. Not with your cervical spine fractured. Not with the unbelievable extensive injuries in which she had, and deep cuts that required stitches that are not superficial. Those are the things that we have to look at. And again, it is so unbelievably difficult, guys, because I know that it's like the loss of these beautiful babies that should be here is unimaginable. Lindsay's not stating she didn't do this. There's an admission. And now what we are trying to do is see if the Commonwealth is able to prove that she was of sound mind, or if she was suffering from mental defect at the time of the crime. And that is why we have that defense. And do you think it's appropriate for a paralyzed woman whom tried to end her own life as well, not just family annihilate, that she go to a prison for the rest of her life or be in a psychiatric ward. They can review it as much as they want. She's never getting out. There's 3 children. So it's Tewksbury State or Framingham, which not even Framingham anymore. I don't know where the women go. Where do women go to prison now? We used to have one in the Commonwealth. Framingham was our women's prison. Now it's closed down. Where was, well, never mind. But it's just sad. It's sad all around. But I find this shit very interesting. All of us, keep your eyes open. The medical, the forensic, all the findings will lead us to the truth. And that's why we do it. Okay, let's see what's going on here. 10 Jules, thank you for E-Chase. I appreciate you, Flexi Heart. Everybody, it's already 6 o'clock and we've missed Esty. She's doing a giveaway with James Jackson at 6 o'clock. Bop over to see her. And to Gina Ann, 78, awful care, shocking. No wonder you all are talking all of our nurses plus sending back our cops. Irish nurse here. In acute, I've seen it twice and 3 times in acute. I think she's talking about, what are we talking about here, Gina? What did we say that we've seen? Oh, visual hallucinations in acute care. It's rare. Same for me. Thank you so much. And to Jeno, thank you for sending 30 Jules to Clutch, Clench, and Kegel all the way home, babe. Massachusetts Sea Glass has been a member at my house for 7 months and haven't seen anyone cry louder than LC for help. And Patrick. Help. Please help. Right? And Veronica, thank you. I hope you're still here with me, babe. I know, shitty day. Happy hump day, though. And Russ TB Bed Springs, thank you so much for the $20. Says, I'm so behind. My mother was an RN and I helped her color her vascular coloring book. I love your layman breakdowns. Transection. Oh, we missed that. Nurses do God's work. Oh, thank you so much. I appreciate you. Yeah. And listen, I don't even know what I'm doing. I'm just trying to talk and tell you my opinion, guys, and you can think differently than me. My chat is always a place for different opinions as long as we're all respectful. I think that it's good to have opposing views, right? I understand people that are like, God, I just can't get past it, Kim, and I get that. But for me, I see the case law. I see the law. And the only reason I want to cover it is because I think it is going to change outcomes so that we don't have to have another loss of life. And maybe there could be an act that would be like a Cora Act or, you know, I don't know. That like when you reach a threshold or there's a flag in medications or you have to stay for a specific amount of time and be seen by, I don't know how many physicians. I don't know what would make it better if we don't reduce the stigma, and the stigma still exists. So that's why when we say like, hey, my name is Kim, I had postpartum anxiety, I hope that takes it away from you if you're carrying the burden or you think it's all, everyone's supposed to know what they're doing. We don't. There's no manual being a parent. And we're just doing the best job we can. It doesn't matter how educated you are, how affluent you are. It could come for any of us. And seeking help and having the correct outlets is the only way to make change. All right. I love your faces. Be good to yourselves. Be good to each other. I'm going to bop on tomorrow. Okay. I love you. Hope this made sense. If it didn't, tell me about it. Tell me about it another day. Okay. I'm doing my best. All right. Bye.